Da se sa crveni ima ovaj desni.
Desni.
Samo što jednom je ovo.
Da, i... Hello, ladies and gentlemen. Welcome to high-level scientific meeting with political goal titled HCC as the result of the unmet needs of silent liver epidemics. We are honored that you have recognized this event, the importance of this event, and you have joined us in this hybrid form. Let me tell you at the very beginning a few words about the organizers of today's event. The Croatian Society for the Liver Disease Hepatos was founded back in the year 2000 as first hepatitis patient association in Croatia. Today, Hepatos is a leading civil society organization that has played a crucial role in ensuring that viral hepatitis is recognized and put on the policy agenda. Having earned the trust and recognition of patient community, society has recognized the future needs of its beneficiaries and expanded its activities to all liver disease. Hepatos activities are performed at the national and international level with membership in the European and World Organization of Related Societies. And we're known project InfoHep Center, which is recognized not only in Croatia, but through the region as best example of good practice thanks to linkage to care services it provides with its mobile unit. This year's Croatian Liver Week is organized in partnership with Croatian Society for Gastroenterology and will hold in two parts, two sessions. First, two-day international scientific meeting with political goal. And second part, two-day public action with mobile clinic, mobile InfoHep Center. In keeping with Hepatos' a long tradition with these events, we continue our work on collecting first-hand reports on liver disease. Disseminate up-to-date information on liver disease and in line with current times, examine the impact of COVID-19 pandemic on liver disease. In order to better present the latest information, the events will be performed under the high auspices of the President of the Republic of Croatia and Ministry of Health, and the event has been endorsed by the European Association for the Study of the Liver. And now, ladies and gentlemen, now on with the program. It's my pleasure to invite the organizer, Tatiana Reich, President of Hepatos, to address you all with welcome remarks. Tatiana.
Thank you. Thank you, Daniela. Maybe the camera could move to my direction.
Okay.
Yeah. Do you hear me?
Okay.
It's okay.
Okay.
All right. So here I am. Well, you do not see me at the moment, but I have a very nice mask with the logo of Croatian Liver Week, but that's me under this mask. Anyway, let me say hello. Let me say, dear all, dear distinguished speakers, dear representatives of societies, expert societies, dear experts who are here in person, and dear, most of all, dear patients, dear fellow patients, because we must not forget that we are here all because of patients and their disease. So thank you for joining us today and dedicating your time today. Liver patients, like their disease, are often silent about their problems and so often forgotten or lost in the sea of issues we face each day. So we must make sure their voices are heard and their needs met. Last year 2020 has left us all tired and craving return to normal, but it has also reminded us of the strength of unity, power of resilience, joys of creativity, and enormous capacity for compassion we all have, and we must continue to use those virtues in order to do our best and help all. Today's event is dedicated to hepatocellular carcinoma as the result of unmet needs of silent liver epidemics. We still don't have a clear and concise picture of a full burden COVID-19 left on our society, especially considering the geographical variations and irregular evaluation of the pandemic across European Union. However, we do know there have been reports of delays in cancer screening and diagnosis. So as representative of the liver patients, I welcome all efforts global community is investing in helping those at risk. And that's why I'm happy that so many of distinguished stakeholders has given their contribution to our event as the recognition of the importance and power a patient's voice has in society. So for the moment, that would be all for me. And please, Daniela.
Thank you, Tatiana. As we already mentioned, today's event is held under the high auspices of the President of the Republic of Croatia and Ministry of Health, and the event has been endorsed by the European Association for the Study of the Liver. As the first of our distinguished guest addresses, we are honored to hear from Professor Thomas Berg, Vice Secretary of the European Association for the Study of the Liver. In a second. Professor Berg. Ready, steady.
Well, dear colleagues and friends of hepatology, dear Tatiana Rach, President of the Croatian Society for the Liver Diseases Hepatos. My name is Thomas Berg and I'm the Vice Secretary General of EASL. And it's really my pleasure and honor and privilege on behalf of EASL and Professor Phil Newsom, the Secretary General of EASL, to extend my best wishes to the Croatian Liver Disease Society Hepatos and the Croatian Society of Gastroenterology, as well as all the stakeholders involved in the organization of this high-level meeting, and especially also all those people who care for patients with liver disease. I would especially like to congratulate you and the organizers for an excellent and highly topical program covering the topics of highest interest. The COVID pandemic is still a major challenge that has also affected and changed medical societies and medical science in general. And I think by holding this Croatian Liver Week, you, Tatiana Rach and Ivana Mikolasevic, the Croatian Society for Liver Diseases Hepatos, and the Croatian Society of Gastroenterology are making an important statement regarding the current needs, achievement, and challenges related to common liver diseases such as viral hepatitis, NASH, NAFLD, and liver cancer, and their consequences for patients. Well, one of your high-level scientific meeting with a political goal is entitled HCC as a result of the unmet needs of silent liver epidemics. Liver cancer is on the rise in Europe, and I realized that liver cancer is one of the 10 most common cancers also in Croatia. EASL really fully shared your view and supports your PPH, public and policy health plan, to include liver cancer in the section on cancer prevention through infections. Few cancers would be as preventable as liver cancer, and this disease deserves priority at the European level under the EU Beating Cancer Plan. So EASL is very pleased to further support your joint long-term efforts, and we thank you very much for the invitation and the opportunity to speak to you briefly. I wish you all an interesting and exciting event. And I also hope to see you soon during EASL's International Liver Congress starting on 23rd of June, and really very much looking forward to the time that allows us to savoring science together again in person. With my deepest respects and thanks and best wishes. Bye-bye.
Thank you, Professor Berg. And now, ladies and gentlemen, we are happy to say hello to newly appointed liaison officer in WHO Country Office Croatia, Iva Pejnović-Franelić.
Excellencies, distinguished guests, dear colleagues, ladies and gentlemen. First, I would like to thank the organizers for inviting WHO Country Office and me here today to address you with a few words. As you may know, 5 years ago, in 2016, the World Health Assembly has adopted the first ever global health sector strategy on viral hepatitis, setting the goal of elimination of viral hepatitis as a public health threat. Reduction of hepatitis-related deaths by 65% and number of new chronic infections by 90% from the 2015 baseline by 2030. Namely, in the WHO European region, hepatitis B and C remain a serious health threat, constituting the highest burden among chronic infectious diseases. Updated estimates just published in the Global Progress Report on HIV, viral hepatitis, and sexually transmitted infections 2021 show that around 107,000 people died in 2019 due to hepatitis B and hepatitis C related liver disease. The Global Progress Report documented many important developments, both globally and in the region, like increasing political commitment. More and more countries are adopting national hepatitis elimination plans, expanding access to hepatitis treatment, particularly hepatitis C, a sign of decline in mortality trends, showing that essential intervention along the continuum of care are effective. However, this report also revealed remaining gaps, and these are the scale-up of diagnosing yet asymptomatic patients with chronic infection has been slow. Only few countries are on track towards elimination, and this is mainly to the undiagnosed fraction, as barriers to treatment access are now mainly removed. Prevention among population at risk has not been sufficiently addressed in most of the countries. Still, there are major gaps in hepatitis data. WHO works closely with ECDC, supporting countries in Europe in their efforts to improve hepatitis surveillance and monitoring, including more precise estimation of hepatitis mortality that will help to highlight the link between chronic infections and liver cancer. Now, as we are all too well aware, COVID-19 crisis affecting health system capacity across the globe has also put under risk our targets for hepatitis elimination, mainly through slowing down case finding, resulting in delayed diagnosis that might lead to more cases of advanced liver disease if we don't catch up and don't build back better. Just 2 weeks ago, on 27th May, WHA 74 delegates agreed to develop new global health sector strategies on HIV, hepatitis, and STIs, addressing significant gaps in reaching the communities most severely affected and at high risk. The new global strategies shall be presented to WHA 75 in May 2020. And already next week, WHO Regional Office for Europe will organize a region-wide virtual consultation on their development. We remain committed to the elimination goal, aspiring to benefit from the lessons learned and promoting better integrated person-centered approach towards universal health coverage. Let me wish you a very successful and fruitful meeting as well as public event. Thank you for your attention.
Thank you, Mrs. Pejnović-Franilić. And ladies and gentlemen, on behalf of Ministry of Health of the Republic of Croatia, Minister Vili Beroš has recorded a few words.
Poštovani uzvanici, kolegice i kolege, zadovoljstvo mi je pozdraviti vas na događanju povodom Hrvatskog dana jetre. Danas se smatra da su kronične virusne infekcije hepatitisom odgovorne za oko 2/3 svih slučajeva raka jetre, najčešćeg raka u mnogim dijelovima svijeta. Prepoznala je to i Svjetska zdravstvena organizacija koja ulaže velike napore u eliminaciji virusnih hepatitisa do 2030. godine. Prioriteti su to i za Hrvatsku, koja je sa 30-ak transplantacija jetre na milijun stanovnika zadnjih 10 godina u samom svjetskom vrhu. I u pandemijskoj 2020. godini ta stopa iznosi 23,2 na milijun stanovnika. Svoju smo ulogu na nacionalnoj razini usmjerili prema aktivnostima i ciljevima koji će zasigurno pridonijeti pozitivnim promjenama i na međunarodnoj razini. Sa ponosom možemo reći da se naše aktivnosti provode u partnerstvu sa udrugom Hepatos. Snažno podržavam poruku ovog događaja usmjerenog podizanju svijesti o problemu virusnog hepatitisa, jer samo zajedničkim radom možemo postići daleko veće rezultate na ovom području. Zahvaljujem na pozivu te vam želim puno uspjeha u daljnjem radu. U srdačne pozdrave, svako dobro vam želim.
And now allow me to read the short statement from the President of the Republic of Croatia, sent for this occasion, which in Croatian you can see on the screen. It's my pleasure to support Croatian Liver Week this year held under the title, All Issues in New COVID-19, Post-COVID-19 World. Given the current COVID-19 epidemic, I believe that this expert gathering with international participation will enable a quality exchange of knowledge, information, and experiences of latest work with liver disease and help raise public knowledge and awareness about the importance of prevention, diagnosis, and treatment of liver disease. With a sincere wishes for a successful event, I extend my greetings to you, your associates, and all participants. Ladies and gentlemen, these were the words of our president, Zoran Milanovic. Let me remind you a few facts about today's event. We mentioned that organizer is Hepatos, and it's under high auspices of the President of the Republic of Croatia and Ministry of Health. But this event is also been endorsed and co-organized by the Croatian Gastroenterological Society, Croatian Society of Internal Medicine Oncology, Croatian Society of Diabetes and Metabolic Diseases, Center of the Ministry of Health for Diagnosis and Treatment of Viral Hepatitis, and Reference Center of the Ministry of Health for Diabetes. We mentioned before that during this liver week, the liver week in period from June 19th to June 12th, is organized in partnership with the Croatian Society for Gastroenterology and will hold 2 days international scientific meeting with political goal. They first HCC as the result of the unmet needs of silent liver epidemics today's event, and they two NASH Day as a part of Croatian Liver Week. It will be in Rijeka on the Adriatic coast on the 12th of June. And 2-day public action will with mobile clinic, mobile info hub center. First is a NASH Day, 10th of June in Zagreb, Croatia, and the second day is in Rijeka again, second NASH Day, 11th of June. That's all what we mentioned, but at the very beginning, we have some technical problems. We have to do some switch. The first participant, the first speaker will be the Professor Colombo. As you know, this part is part of our program titled Current Landscape of HCC. And the first on the program is Professor Massimo Colombo, Director of the Center of Translational Research in Liver Disease at Humanitas Research Hospital, Rozzano, Italy. And Professor Colombo is well known to us all for the various roles he has as a member of many professional societies, including EASL, AASLD, and several Italian societies. Not to mention recipient of numerous awards. And Professor Colombo joining us today with presentation titled HCC Advances in Diagnosis and Prognosis. So let's roll.
Good morning, ladies and gentlemen. It's a great pleasure for me to be here discussing advances in diagnosis and prognosis of liver cell cancer. These are my financial disclosures. As you know, liver cell cancer is a major medical and social burden. Depicted here are in fact the survival rates for liver cancer in various geographical regions of the world. And you might immediately appreciate that in those countries that are classified as a low socio-demographic index regions, China and Egypt, the survival rates are really dismal. And the obvious explanation for the discrepancy between the richest and the poorest geographical areas of the world is that in the very last one, screening aimed at early detection of liver cancer is faulty. The liver scientific societies, the American, the Asia Pacific, and as far as we are concerned, the European Association for the Study of the Liver have released a recommendation on how to screen patients at risk of liver cancer. And we believe that the ideal target are those patients with advanced liver disease, particularly patients with cirrhosis, including those with decompensated cirrhosis who are listed to liver transplantation. And the optimal modality for screening is ultrasound delivered every 6 months. While doing so, you are in a position to identify a tumor at a very early stage that is suitable to be eradicated quite easily, at least compared for tumors with a more advanced size, translating into an improved survival, which is at least double as expected in those who are left unscreened. However, to achieve such ideal goal, screening program needed to enjoy optimal adherence. At least more than 59% of patients should adhere to the protocol of 6-monthly screening, which is not exactly the case for each subtype of patients. We will be discussing this. And another option to improve the outcome of screening is to combine surveillance with ultrasound with a test, a serum test for alpha-fetoprotein that alone is not effective at all, but when it is combined with abdominal ultrasound, makes the outcome of screening jumping up from 45% of early detection to 63%, at least according to this meta-analysis of 32 studies with more than 13,000 patients enrolled that has been published quite recently in gastroenterology. Once you are in a position to deliver an efficient surveillance program, you have to deal with another important barrier, which is etiology of the underlying liver disease. In this prospective multicenter study done in Italy by Professor Piscaglia in Bologna, it is quite clearly demonstrated that patients with an HCC related to metabolic syndrome, NAFLD, fatty liver, enjoy less chances of being detected at an early stage compared to those patients who have their cancer related to chronic infection with hepatitis C. And the difference is related to the fact that patients with hepatitis C are readily identified by practitioner and community doctor and, enroll into program of screening and early diagnosis compared to those with fatty liver that are many, one quarter of the general population, and less often addressed to an effective surveillance programs. Possibly one reason why patients with fatty liver are not enrolled straightforward to surveillance with abdominal ultrasound every 6 months is the fact that only half of these patients have stigmas of cirrhosis. In other words, cancer in fatty liver might develop directly from liver inflammation bypassing the stage of cirrhosis, which is considered preliminary and an important starting point to deliver surveillance with ultrasound. However, quite recently, there has been a number of studies that are telling us that we could stratify the risk of liver cancer in patients with fatty liver just applying clinical methodology. Patients harboring more than 3 metabolic traits, diabetes, arterial hypertension, and obesity, have a far greater risk of developing a liver cancer compared to those who have only 2 or 1 of these metabolic traits, not to speak about those having none. So, for instance, when the community doctor meets a patient with fatty liver, he should look for the metabolic traits, and if they are present, this patient should be definitely put into surveillance with abdominal ultrasound because the risk of developing cancers is much higher than the rest of fatty liver patients having no metabolic trait associated. However, once the doctor is able to address the patients to a surveillance program, he could realize that screening patients with NAFLD, in this case, patients with non-alcoholic steatohepatitis, have a far greater risk of a faulty screening, inadequate exam being carried out in patients with heavily infiltrated livers with fat or obese population. And in this important study, with almost 1,000 of patients undergoing surveillance with ultrasound, it was clearly demonstrated that etiology matters, and that one of the important reasons why NASH-related cancer is hard to be efficiently detected by ultrasound. You see, the inadequate assessment is more often here in NASH-related cancer. It is because of its association with obesity, particularly morbid obesity when BMI exceeds 40. A way to counteract these methodological flaws imposed by obesity or by heavily infiltrated by fat livers is to switch from ultrasound to MRI. Unfortunately, MRI is a costly procedure and is not as widespread as ultrasound, and is just present only in dedicated radiological department, and is quite sophisticated to be used. But there are some experts that are advising us that screening could be run using MRI in a very, very simplified manner. For instance, using multi-sequence, non-contrast-based MRI, or DWI, which means diffuse weighted imaging. And these two methodologies would allow patients with fatty liver and patients with other etiology of liver cancer to be identified quite early with a greater sensitivity than ultrasound, in the range of 88% in those greater than 2 centimeters, and even 77% in those with less than 2 centimeters. And if you work using DWI, you might raise specificity to up to 97%, possibly losing a little bit in terms of sensitivity. So this is another option. But of course, for instance, in countries like Italy, this is not actionable because magnetic resonance equipments are fully dedicated to investigate the abdomen for a reason other than identify a patient in a wealthy domain, in a wealthy environment, using non-contrast MRI. You need to put the patients, to give the patient a robust, definite diagnosis of liver cancer. And you might utilize contrast imaging. Multi-phase CT scan or extracellular contrast MRI are recommended by EASL, the American Society and the Asia-Pacific Societies, as a modality that provides a final diagnosis. Why? Because in patients with cirrhosis, the liver is heavily nourished by vein. And when you inject the contrast, if in the context of this venous domain, you identify a small lesion which is rich in artery, become whitish with the parenteral contrast, this means that this is a lesion enriched by arteries, and only cancer is enriching with arteries. Later on, when the contrast goes perfusing all the organs and leaves the arterial phase and moves into the venous phase, the liver becomes whitish because the cirrhotic liver is nourished by veins, and the original lesions that was whitish during the arterial phase become black. And this is called wash in, and this is called wash out. So in a cirrhotic patients found to have a small nodule at ultrasound or MRI with a wash-in, homogeneous wash-in and a homogeneous wash-out, the diagnosis of liver cancer is considered to be definite. These now obviously raise a number of arguments because comparison between contrast CT scan and contrast MRI provide some discrepancies in terms of diagnostic effectiveness. In this important meta-analysis, this pool analysis done by the American Society of the Liver a couple of years ago, you might realize that for nodules between 1 and 3 centimeters, as usually are found during screening, the sensitivity of MRI is much better than sensitivity of a CT scan. And MRI even more outperforms CT scan when the nodules is only 1 centimeter. These nodules, the 1 centimeter nodules, are an issue because if you fail to demonstrate wash-in, wash-out, which happens in more than 30% of the case, you cannot utilize liver biopsy because if you perform a liver biopsy in these small nodules, you face the risk of 30% of false negative result because the needle goes everywhere but in the cancer. It's too small tumor. So the only way out is to run rounds of imaging, contrast imaging every 3 months until the tumor grows or changes its vascularity to become actionable with imaging or big enough to undergo a performant liver biopsy. Liver biopsy, generally speaking, is not being performed in those tumors that have been appropriately diagnosed by imaging. You see, only 10%. And this is the basis of standard of care of these patients since 20 years, whereas liver biopsy is performed in other situations where wash-in or wash-out is lacking. However, an argument has recently been raised that we should perform more liver biopsies also in this setting of wash-in, wash-out positive nodules. Why? Because in a couple of studies, including one done by us in Milano, 10% of the nodules arising in cirrhosis that show washing, homogeneous wash-in and wash-out at MRI or with CT scan are indeed intrahepatic cholangiocarcinoma that requires a completely different therapeutic approach with respect to hepatocellular carcinoma. And this is an important point. Why? Because a correct diagnosis and a perfect staging of the underlying liver disease allows hepatologists to make a robust prognosis and to choose the right treatment modality for his patients. If the patient has a very well compensated liver, Child-Pugh A, or a fairly well compensated liver between A and B, and a very small nodule, less than 2, or an early stage, less than 3 nodules, each of or equal or less than 3 centimeters, these tumor patients can be treated with a radical approach that goes from simple ablation through echo-guided radiofrequency or microwave ablation to hepatic resection, particularly if the patient lacks portal hypertension, important portal hypertension, particularly if the tumor is located at the periphery of the liver, and it is, a patient's fit with respect to other comorbidities. Is not obese, has no hypertension, has no diabetes, and so on. For those patients who are, surgically speaking, good candidates, but are not actionable in terms of radiofrequency or resection, the only real solution is liver transplantation. That can only be provided to patients with an intrahepatic tumor in fit conditions in terms of comorbidities and age cutoff, let's say less than 70. For all those patients who have more advanced tumor, particularly those with intermediate multinodular cancer, all remaining entirely within the liver domain, in good performance status, ECOG 0, these patients are generally treated with chemoembolization that can lead to shrinking of the tumor, and in some instances also, these patients can then be considered for liver transplantation as well. But if they are not fit for this treatment because they have certain comorbidity as severe, for instance, atherosclerosis or other issues that cannot be treated with chemoembolization, for instance, low platelets here and there, they today can be assisted with systemic therapy. So for those not responding to chemoembolization or having particular comorbidities, systemic therapy with these regimens are now available. That, of course, represent the ideal treatment modality for patients with advanced cancer, those who have portal invasion, localization of the tumor in the lymph nodes, or metastatic to the skeleton, or to the liver in both lobes, or to the lungs, with a still fairly compensated liver disease. Today, systemic therapy has moved ahead with a combination of these immune checkpoint inhibitors plus this monoclonal antibody that inactivate VEGFR, and altogether this new regimen is considered to be the ideal first-line therapy. It will be entering the market in Italy in October. And what used to be the first line, like sorafenib and lenvatinib, TKI, tyrosine kinase inhibitors, now they have been shifted to a second-line therapy, and those who were until yesterday the second line after sorafenib, like regorafenib for those who can tolerate sorafenib, cabozantinib, or ramucirumab for those having a cancer with very high levels of alpha-fetoprotein, have become a third line. Meaning that today, if the patient is very well staged for the underlying liver disease and is in an ideal therapeutic setting, can enjoy very prolonged survival if he is in a position to undergo radical therapy with transplantation, 80%, 90% survive in 10 years, and even more so for those patients with hepatitis B and C who can enjoy virus suppression or elimination with antiviral therapy. A reasonable median survival for patients undergoing chemoembolization, and today 19 months in first-line therapy to be followed by additional survival months if you can apply second and third line. To tell you that today, the scenario of hepatocellular carcinoma therapy has greatly improved thanks to our ability to perfectly stage the patients and respecting the guidelines released by the scientific society. And why future is inspiring? Because there is a number of investigations going forward that are evaluating the effectiveness of adjuvant therapy. So combining systemic therapy with this new developed regimens and radical therapy, plus treatment of intermediate patients with a combination of systemic therapy and chemoembolization. Not to speak about the fact that in the domain of patients with advanced liver cancer, there are a number of studies that are evaluating different combination between immune checkpoint inhibitor of different classes or combination with newly developed drugs together with previous existing drugs, one above all, the combination of radiotherapy with yttrium with the old TKI sorafenib. So all in all, what I like to say is that we have done big step forward in the diagnosis and management of liver cell cancer in the very last 20 years. Thank you for your attention.
Thank you, Professor Colomba, and dear participants, we are honored to have Professor Stjepko Pleština. Professor Pleština offers his overview of the HCC situation in Croatia from all aspects and include latest ESMO guidelines. Professor Pleština is an internal medicine specialist focusing on internal medical oncology. Professor Pleština is head of the oncology clinic, head of the Department of Digestive Tumors, full professor at the Faculty of Medicine, University of Zagreb. Professor Pleština, the floor is yours.
Thank you. I'll try to share my screen with you. I have some technical problems because I'm out of office, but I hope it will be possible to present. Can you see my screen?
Yes.
Oh, thank you. Thank you.
Marvelous.
First of all, I want to thank the organizer for his continuous efforts in the fight against hepatocellular carcinoma. Still nowadays, one of the solid malignancy among those with the worst prognosis, unfortunately. So it's a sixth cancer entity and fourth cause of cancer death worldwide. Among all types of primary liver cancers, hepatocellular carcinoma is taking about 90% of all. Liver cancer has a mortality to incidence ratio about 93%. So it's making it a major cancer entity with the poorest prognosis. So global incidence is still highest in developing regions. Men have a roughly threefold higher risk of developing liver cancer than women. And about 80% of new liver cancer cases occur in less developed regions, but also in Western countries, in Europe and United States, we can see about 5% increase per year in incidence of hepatocellular carcinoma. So what is the situation in Croatia? Is among men, 10th cancer entity and 7th cause of cancer death in our country. So if we talk about stage in a moment of diagnosis, more than 50% of all patients present with advanced hepatocellular carcinoma, not suitable for surgical treatment, neither for transplantation. So what's not good, you can see here, more than 50% of patients, we don't know the stage of the disease in a time of diagnosis. So we know that cirrhosis is the predisposing factor for the majority of hepatocellular carcinoma cases. Almost 90% of hepatocellular carcinoma arises from cirrhosis. Cirrhosis-induced alterations to the liver microenvironment and can be considered as a necessary predisposing factor for the most cases of carcinoma. So risk factors vary by geographic region. Still, hepatitis B and C prevalence is increasing, and also together with alcohol consumption, the main reasons, main etiological factors for hepatocellular carcinoma, but also non-alcoholic fat liver disease and steatohepatitis are becoming increasingly important risk factors for hepatocellular carcinoma, especially in Western countries. Most heavy drinkers have fatty liver, and about 1/3 them will progress to alcoholic hepatitis, and about 20% will progress to cirrhosis. So that is a very important risk factor. Other less common risk factors for HCC include autoimmune hepatitis, primary biliary cirrhosis, obesity, diabetes, and also environmental carcinogens, including aflatoxins and other toxic chemical compounds. What about surveillance in patients at high risk of HCC? Here are guidelines presented. Surveillance is recommended in specific target populations with quite low level of evidence, but very strong grade of recommendation. In cirrhotic patients, Child-Pugh stage A and B, cirrhotic patients, of course, Child-Pugh C, awaiting transplantation, but also in non-cirrhotic patients with B infection at intermediate or high risk for HCC. So that is also low level of evidence and quite weak grade of recommendation. So a 6-month interval is reasonable and cost effective. There is no clinical benefit with 3 months, but also we know that if we use 12 months, we will find fewer early stage diagnosed patients than in a shorter interval. Diagnosis generally relies on pathology in all malignancies, but we can use non-invasive criteria in patients with clear cirrhosis. So again, with high level of evidence and strong grade of recommendation, diagnosis of HCC can be made in cirrhotic patients and be based on non-invasive criteria. On the contrary, in non-cirrhotic patients, diagnosis of HCC should be confirmed by pathology with moderate level of evidence, but strong level of recommendation. So in non-invasive diagnosis, we have guidelines telling us that non-invasive criteria can only be applied to cirrhotic patients for nodules for 1 or more centimeters in height, and a height for pretest probability, and are based on imaging techniques obtained by multiphasic CT or dynamic contrast enhanced magnetic resonance. So because of the high sensitivity and the analysis of the whole liver, CT or MRI should be used first. High level of evidence, strong grade of recommendation. On the contrary, FDG PET scan is not recommended for early diagnosis of HCC because the high false negative rate. Algorithm for diagnosis and recall in cirrhotic liver differ between nodules less than 1 centimeters or more than 1 centimeters and are quite clear and established widely. HCC is a disease with very complex pathogenesis. Chronic liver damage is its central on the beginning, both with B or C virus or any other of risk factors. We know that key oncogenic networks drive HCC development and then give a metastatic potential. So all are very important, especially vascular endothelial growth factor A overexpression. We know that is associated with poor prognosis in HCC. HCC is a tumor with very extensive hypervascularity, driven in part by the angiogenesis regulator. The main is VEGF-A, whose amplification are found in about 5% of HCC cases. So a VEGF-A amplification induces neoangiogenesis and tumor proliferation by inducing macrophage-mediated hepatic growth factor secretion. Also, the RAS-MEPK pathway, very common and important in malignancies, is overactivated in hepatocellular carcinoma. So it's very important to say that liver tumors are not highly immunogenic. That is very important if we think about immunotherapy, checkpoint inhibitors. Tumor mutation burden and microsatellite instability have been associated with high immunogenicity. So the liver is characterized by a strong intrinsically immunosuppressive environment. Liver is often described as being immunologically tolerogenic, which is supported by the low levels of immunosuppression typically required for liver transplant patients. The immunosuppressive environment of the liver may represent a major barrier to effective anti-tumor responses. So we need to think how to rise the immunogenicity. Usually we use BCLC, that is currently the most commonly used staging system in Western countries, because we have a standard in other tumor types, TNM classification, but that is only one piece of HCC classification and puzzle. So BCLC is most used staging system because it uses variables related to tumor stage, but also liver functional status, physical status of the patient, and cancer-related symptoms if they are present. So BCLC is widely used and utilized treatment recommendations also for each stage based on best available options we have today. So if we look at the proportion of disease stages as diagnosis, I said before, about 50 or more patients will present with advanced HCC, and they are not candidates for surgical radical treatment. So we need better systemic treatment. Here is HCC treatment landscape. After a few decades of negative studies, negative trials, we don't have any overall survival benefit with any cytotoxic chemotherapy. Anthracyclines are commonly used, but without success in the meaning of overall survival benefit. 15 years ago, we have a sharp study. Sorafenib was the first drug with positive, statistically positive clinical trial compared with placebo. After that, we have lenvatinib few years after, 10 years after, with non-inferiority study comparing lenvatinib with sorafenib. And again, after few years, we have success with combination of checkpoint inhibitor atezolizumab combined with VEGF inhibitor bevacizumab. Few new drugs are also under investigation. So our treatment decisions must be influenced by disease stage, but also with the resource availability and local preferences. For eligible patients, of course, the ideal course of action is transplantation or surgical resection. In those who are not candidates for surgical treatment, local regional therapies such as transarterial chemoembolization or radiation are the possibility. But for more than 50% of patients, systemic treatment or just symptomatic treatment are options. Clinicians must also consider underlying liver disease before selecting of our systemic or local treatment. In early stage, of course, surgery, transplantation or resection, transplantation because it's a way to cure both diseases, liver disease, underlying disease, and at the same time malignant disease. But using Milan criteria or San Francisco criteria, patients will have a chance to be cured, but also we need another options. Several local regional therapies are available with varying advantages and disadvantages, and we need to find the best option for each patient using our knowledge to meet the best option. For unresectable disease, we have a rapid progress in ongoing in the first-line treatment. After sorafenib and lenvatinib, now we have an option to use atezolizumab combined with bevacizumab. So sharp trial, 2.8 months delta in survival, statistically significant, but clinically less significant. Then lenvatinib, non-inferior to sorafenib in the first-line treatment. We cannot say it's better drug because it's non-inferiority design of the clinical study. But all systemic therapies until now demonstrate limited efficacy. If you look in an overall response rate, both in the first line and the second line treatment, that's about just few percent of patients will respond. So the benefit in survival is about 3 months, so less than 1 year of survival for our patients with advanced disease. So the combination, few words about combination of checkpoint inhibitor atezolizumab and bevacizumab. Bevacizumab is drug who promotes the maturation of dendritic cells, then promotes T cell activation, but then normalized tumor vasculature, increasing T cell infiltration in malignant tissue, decrease of activity of immunosuppressive cells, and then restore anti-cancer immunity with atezolizumab. Few words about IMbrave 150 phase 3 clinical trial comparing first-line atezolizumab plus bevacizumab compared with sorafenib. A clear advantage in survival, both progression-free survival and overall survival. Also, tumor response about 3 times more than with sorafenib. And please look at complete responses. About 8% of patients had a complete response. I don't remember that I any time see the complete response with sorafenib or any TKI inhibitor. What about adverse events? Adverse events are quite okay. So atezo plus bev combination is without any serious adverse events compared with sorafenib. Quality of life is preserved and deterioration of the ECOG status is less with atezo-bev compared with sorafenib. And what about progression? We have a few second-line agents for unresectable HCC, which are approved, but also they are approved after prior sorafenib treatment. We don't have positive clinical studies after immuno-atezo-beva combination. So decisions of second-line systemic treatment must also consider tolerability and impact of patient quality of life, which is very, very important part in those patients. ESMO guidelines recognized atezo-beva for first-line option in patients with BCLC stage, and after that, in second-line treatment, sorafenib or lenvatinib or regorafenib or cabozantinib or ramucirumab. So that's our options for a second-line treatment. The similar situation is if you look at NCCN guidelines. So we have options in the first-line treatment better than before, and also in a second-line treatment. Very important is multidisciplinarity and treatment in high volume centers with experience and knowledge about all possibilities of treatment of patients with hepatocellular carcinoma. So thank you for your attention.
Thank you, Professor Pleshtina. I would also like to remind all participants that if they have any question for today's speaker, to feel free to post them in our chat section, and we will try our best to have them answered, if not immediately, then throughout the event. Next, we are joined by Primarius Danko Mikulic, an attending general and transplant surgeon at the Department of Surgery at the University Hospital Merkur in Zagreb. His primary interests in research include hepatocellular carcinoma, pancreatic cancer, organ donation, and allocation. Professor Primarius Mikulic will present surgical treatment HCC, liver resection versus liver transplantation.
Thank you, Daniela, and also thanks to the organizers for the invitation. Good morning, dear colleagues. I will try and give an overview of the current aspects of liver surgery and liver transplantation for HCC. Can you help me with the pointer? Okay. Just a short outline. I'll give a brief introduction, then an overview of surgical treatment of HCC in the non-cirrhotic and cirrhotic liver, current trends in the selection criteria for liver transplantation, status of primary resection versus salvage transplantation for HCC, and finally some strategies in order to increase the availability of grafts for liver transplantation for HCC, but also for other indications. Just to illustrate our current situation in Croatia, this is a slide showing our situation at a busy liver transplant center in Croatia at University Hospital Merkur in Zagreb, where we annually perform between 100 and 120 liver transplants. And you can see that in the pre-COVID years, HCC took up to between 20 and 35% of our case mix. It is even more drastic in the COVID years or 2021, but I guess these 2 years are not really relevant. As we have heard before, hepatocellular carcinoma is increasing both in incidence and as a cause of cancer-related mortality, and surgery, whether in the form of resection or in the form of liver transplantation, is still the only potentially curative option. Figure-wise, it means that we have about 50,000 of new cases every year in Europe, out of which about 20% are upfront metastatic, therefore not amenable to surgical treatment. However, this leaves about 40,000 potentially either surgically curable or transplantable cases. As for the figures from the European Liver Transplant Registry, out of the 7,000 liver transplants performed every year in Europe, about 1,000 are performed for HCC patients. HCC, non-cirrhotic liver, is still best treated by surgery. Preoperative biopsy is crucial to inform us on inflammation, fibrosis, steatosis of the liver. All of these conditions have very much impact on the outcomes and especially on the post-operative and perioperative development. As we have heard in the first presentation by Professor Colombo, NAFLD is a whole different HCC occurring in NAFLD is a whole different topic with its own specifics, including steatosis of the liver, considerations regarding its size, very early spreading out of the criteria for transplantation, comorbidities, metabolic syndrome, etc. In the recent years, liver surgery has, along with interventional radiology, has given us a lot of new approaches and new solutions for liver tumors, including HCC, of course. These include portal vein ligation or portal vein embolization in order to induce liver hypertrophy, ALPS, which is an innovative two-stage liver resection with ligation of the portal vein, also in order to induce liver hypertrophy of the future liver remnant. Then there is RAPID, which is a hybrid operation between liver transplantation and liver resection, where initially a partial liver resection is done along with an auxiliary partial liver transplant, and then once the graft undergoes hypertrophy, the rest of the liver, of the diseased liver, is removed. Also, minimally invasive approaches are gaining more and more acceptance. However, there are exceptions. There are cases where we do perform liver transplantation for HCC in non-cirrhotic liver. Basically, this happens in two scenarios. One scenario is recurring HCC in the non-cirrhotic liver, and the other scenario is unresectable tumor in the first place when liver surgery is not possible. These patients are not numerous. However, the data from the European Liver Transplant Registry shows that in contrast to HCC in the cirrhotic liver, here tumor size and number are not always good predictors of recurrence. However, traditional poor predictors like microvascular invasion, positive lymph nodes, and so on do impact on survival negatively. And actually, the 5-year survival for these patients is quite acceptable. We've seen also in the first presentation by Professor Colombo the current guidelines, both European, American, and Asian, for liver resection and liver transplantation in cirrhotic liver. Just to touch upon those briefly, if the tumor burden is acceptable, of course, if there's no extrahepatic spread, no macrovascular invasion, if the liver function is preserved. We are talking about compensated cirrhosis, either measured by Child-Pugh A or sometimes B, or low MELD scores. If the future volume of the future liver remnant is sufficient, and even in the setting of portal hypertension, liver surgery is acceptable. However, there are regional differences. There are differences impacted by the local condition, local situation, both in liver surgery and in liver transplantation. Here is an illustration of Croatian situation. As you may be well aware, we have very good deceased donor organ donation rates in Croatia. Therefore, even in cases of early HCC, we often tend to go for liver transplantation instead of liver resection for several reasons. I will get back to that later. However, one of the most important reasons is the high risk of recurrence with the liver surgery, much more risk for recurrence than with liver transplantation. Of course, there are no randomized controlled trials between the two treatments, so it's hard to quantify that. Now, a couple of slides on liver transplantation. Today, in 2021, we are exactly 25 years from publication of Mazzaferro's paper and basically universal acceptance of Milan criteria for liver transplantation. As you know, these criteria are purely morphological. They only take into account the size and the number of tumors without any regard for the biology of the tumor. And now, as I said, 25 years later, the world is slowly shifting to the biology of the tumors. Of course, not exclusively, because we don't have biologic markers that are that sound to just turn to biology. However, we are trying to incorporate biological markers into our algorithms and somehow combine them with morphology of the tumor. Of course, in liver transplantation, especially in deceased donor liver transplantation, we have to agree on the minimal acceptable survival, because the patients with HCC, therefore patients with malignant disease, are competing on the waiting list with the patients with benign diseases who have very good outcomes with liver transplantation. So equity and fairness have to be taken into account. As for the biological markers, AFP is now universally accepted, either as an absolute value or as a delta, meaning a decrease of the AFP after downstaging or local regional therapy. Then there's DCP or PIVCA. I saw on today's program we have a presentation later on that. So I'm glad. I actually heard that DCP is going to be introduced more into clinical practice in Croatia as well, because now it is more widely used in the East. FDG PET avidity. In the previous presentation, it was mentioned that FDG PET is not a diagnostic. It is not a means to diagnose HCC. Of course, it's not. However, FDG avidity, if there is one, then it is a sign of poor prognosis, often correlated with other poor prognostic signs like microvascular density, microvascular invasion, and poor survival. Response to local regional therapy or downstaging, non-progression or progression during waiting time, inflammatory markers like neutrophil to lymphocyte ratio or platelet to lymphocyte ratio, histology, which usually is not available before surgical therapy, and finally the future genetics and molecular criteria. Of course, the situations in the West and in the East differ because of the availability of deceased and living donor organs. what most of the criteria in the West coming into play now have in common, that we are trying more and more to incorporate the biomarkers, be it AFP or DCP or inflammatory markers, so somehow to build on the sort of robustness and validity of the morphological criteria that we were using before. One of the very sort of user-friendly and intuitive models is the French model, which was introduced almost 10 years ago, but basically in practice about 5 years ago, and now some more countries are also using the same or similar models, incorporating diameter of the tumor, number of nodules, and AFP level, where the 1000 mark is the limit for liver transplantation. East, on the other hand, where living donor liver transplantation is predominant, of course, has different criteria and has sort of a luxury to go for more relaxed and more flexible criteria, because the donors are readily available when the living donor is available, and there's no competition with other indications on the waiting list. This does bring a risk of transplanting patients with unfavorable biology, because there's no waiting on the list. The patient gets a transplant as soon as the diagnosis is present and a living donor is available, and the levels of minimal acceptable survival are accordingly different than what we have in the Western world with the deceased donor organ transplantation. A number of expanded criteria have emerged in the recent years in the East. Common to all of them, they are much more liberal in terms of tumor morphology. That is, some of them even take patients with any size and any number of nodules. However, they try to put more weight and more emphasis on biological markers. Again, AFP, DCP, FDG, avidity. Even portal vein tumor thrombosis is no longer a contraindication in some of the Eastern liver transplant centers. It's very small print and it's almost unreadable. However, it's a protocol from Medanta from India, where the patients with portal vein tumor thrombosis undergo both downstaging of the primary tumor, either using TACE or radio embolization or whatever other means they have available. But the portal vein thrombosis also undergoes downstaging using SBRT, stereotactic body radiotherapy, and then after both tumors or both lesions are downstaged, if there's no PET FDG avidity, the patients are eligible for living donor liver transplantation, actually with pretty good survival rates. In summary, magnitude of transplant offer dictates our decision making, whether to go to surgery or to liver transplantation, and there likely will never be a universal system for all regions and all parts of the world. However, we see a trend towards combined criteria to likely dominate decision making in the future. A couple of slides on salvage transplantation. The concept of salvage liver transplantation emerged about 10 years ago. This is a concept where primary resection is done first, and then in case of a tumor recurrence, liver transplantation follows. These are the results of a more recent analysis It was an intention to treat analysis, and it actually shows that the outcomes of primary liver transplantation and salvage liver transplantation were similar. However, we have to bear in mind that only a small part of the patients that were resected in the first place and then got a recurrence eventually got to a salvage liver transplantation. That is either because the recurrence occurred outside criteria for transplantation, or because of their advanced age beyond the limit for liver transplantation at the time of recurrence, either because of comorbidities or the patients get lost to follow-up or logistics preclude them from transplantation, or they just drop out from the wait list once they get to the liver transplantation wait list. It would be very convenient if we had more information about tumor aggressiveness beforehand, before making the decision whether to go to primary liver transplantation or to resection first. But unfortunately, needle biopsy often doesn't confer that much information in terms of microvascular invasion, tumor grade, and so forth. So it is hard to know in advance. In that case, we could go to preemptive transplantation, or even after the removal of the tumor, one solution could be preemptive transplantation if the histological factors are poor. Another problem is the age of our patients. Average age of HCC patients in Europe at diagnosis is 65. So if they undergo resection first, and then they get a recurrence 2, 3, 4 years after, they risk being beyond the limit for liver transplantation. In Croatia, we are fairly liberal with the age limits because, as I said earlier, we have a lot of donors. However, in most countries, age limit is 65, maybe 70, so that's a problem as well. Finally, in liver transplantation, we are faced with the organ shortage all the time. There are more and more indications. The patients live longer and expect to get a transplant longer and longer. And there are all the time we are striving to find more and more grafts, either through living donor liver transplantation, split liver grafts, donors after circulatory death grafts, marginal grafts. And there's also one positive development we have seen over the last 5 years. That is the decrease of the Hep C patients waiting for a liver transplant. It's really a dramatic drop. Hep C was not so long ago the leading indication for liver transplantation, and luckily, thanks to the direct-acting antiretrovirals, it is really dramatically dropping, and that does leave us a potential surplus of grafts for liver transplantation for other indications. However, there are a number of candidates. It's not just the HCC. So basically, thanks to this potential surplus of liver grafts for transplantation, we have a new field emerging, transplantation oncology. It's an old idea, but in a new time. And as we see, extended criteria, HCC is just one of the indications waiting in line. There's also the Klatskin tumor or the perihilar cholangio. There's hepatoblastoma. There's intrahepatic cholangio. There are secondary liver tumors, neuroendocrine, even colorectal. So I guess the conclusion is whatever we do, and however much more grafts we provide, we are still faced with the organ shortage, and it's not a problem that is going to go anywhere anytime soon. Thank you.
Thank you, Primarius Mikulic. Continuing on to interventional radiology in the treatment of liver cancer, we are happy to welcome Dr. Ivana Jurca, clinical radiology specialist, interventional radiology resident, and Clinical Hospital Center, Zagreb, Croatia. Floor is yours.
Thank you, Daniela. Dear ladies and gentlemen, dear professors and colleagues, good morning. First of all, I would like to thank Mrs. Reich and Hepatos for the invitation. I'm very honored and pleased to be part of this meeting. I'm Ivana Jurca, radiologist from Clinical Hospital Center Zagreb, and my presentation today will be about the role of interventional radiology in treatment of liver cancer. As we all know and have heard before, HCC is the most common primary liver cancer, and even though the screening methods are improving, still most of the patients are diagnosed in the advanced stage of the disease. And we also mustn't forget that liver is the most common site of the metastatic disease. Barcelona Clinic Liver Cancer Classification is the most common and widely used classification in the Western world for the treatment of HCC. It divides patients in 5 subgroups, and as you can see, interventional radiology has its role in a very early stage of the disease, and chemoembolization as an interventional procedure is a treatment option for patients in stage B disease. How do we select the patient? We do it on multidisciplinary team, which consists of the doctors of different specialties, where we together decide which is the best treatment option for each patient individually. Here are all possible interventional procedures that can be performed in patients with primary or secondary liver cancer. First of them are transcatheter intra-arterial therapies. As I mentioned before, chemoembolization is a treatment option in stage B disease. Also, radioembolization can be performed, blend embolization without chemotherapy, or chemoinfusional therapy without embolization. These procedures can be performed because liver has a dual blood supply. Approximately 3/4 of the blood come from a portal vein and approximately 1/4 from the hepatic artery. The tumors predominantly derive blood from the branches of the hepatic artery, and this allows selective therapy delivery to the tumors, and it protects surrounding normal parenchyma from the necrosis. So the goal of TACE is to deliver chemotherapy in the tumor and to cause terminal arterial blockage and tumor ischemia. The chemoembolizations were first performed in the 1980s in Japan, and since 2003 they are part of BCLC classification. In 2002 there were 2 landmark studies that showed a statistically significant survival advantage with the use of TACE versus the best supportive care. There are 2 main types of chemoembolization, C-TACE and DEB-TACE. C-TACE is a conventional TACE which uses lipiodol as an embolic agent. It's a poppy seed oil-based contrast medium. It causes transient ischemia. It is a radiopaque agent, and it retains in tumor for weeks. And because of that, the post-procedural CT evaluation is quite hard. It is most commonly combined with doxorubicin and cisplatin. Another form of TACE is a DEB-TACE. It's embolization made with the drug-eluting beads. These are micron-sized particles made from biocompatible materials such as gel foam, polyvinyl alcohol. They come in different sizes in a wide range from 40 to 900 microns. For liver, we use beads in size from 100 to 300 microns. Before the procedures, these beads are preloaded with doxorubicin. The standard dose that we use per procedure is 75 milligrams. It can be upsized to 150 if the tumor is bigger or if we plan to embolize several nodules in one procedure. This is an example of a patient. On the first picture, you can see the CT with two nodules. It's a stage B disease. The larger one medially placed, it's even partially necrotic. We selectively catheterize the common hepatic artery, and you can see the hypervascular pathological zones. After that, we selectively catheterize only the arteries that vascularize these zones. We do it with a microcatheter, and on the last picture, you can see that there is no more hypervascular zones after performing TACE. Another procedure that can be performed as a transcatheter procedure is a radioembolization. It's a combination of embolization and brachytherapy. It uses small particles like as deptase, but these are loaded with radioisotope. Most commonly used is Y390. It's a pure beta emitter and it has a half-life of approximately 2.5 days. It has limited tissue penetration from 2.5 to 11 millimeters. And this limited tissue penetration allows the local high dose radiation inside the tumor, and it protects from the radio-induced hepatic necrosis. This is an example of a patient with the performed radioembolization. On the first picture, you can see the intraprocedural CT with the catheter placed in the left hepatic artery. These whitish hypervascular areas are the tumors, multifocal HCC. And on the second picture, there is a post-procedural PET-CT, which confirms the focal activity in the tumor, so the radioembolization was performed correctly. This procedure is still not the part of BCLC classification, but there are a lot of studies proving that it does have good tumor response is in HCC and in many secondary liver diseases, such as in metastases from a colorectal carcinoma, neuroendocrine tumors, melanoma, and breast cancer. This procedure is still not available in our country. At the moment, we are negotiating with the Croatian National Healthcare Insurance Company, and we are doing our best to make it possible in our institution and available for the treatment of our patients. Another group of interventional procedures are thermal local regional therapies, such as microwave and radiofrequency ablation. These procedures can be performed in very early stage of the disease. Both of these procedures produce heat and destruction of the tumor. Microwave ablation uses an antenna which propagates microwave energy in the surrounding tissue, which causes heat and destruction. And radiofrequency ablation uses a generator which creates high frequency, rapidly alternating electrical currents. It agitates ions, causes friction and heating and destruction of the tissue. These procedures are performed under ultrasound or CT guidance, and they can also be combined with transcatheter procedures. Here you can see an example on picture A. There is a hypervascular nodule, small HCC. On picture B, there is an antenna and microwave ablation performed of that nodule. On the next picture, there is an immediate follow-up CT control. And on the last picture, you can see a much larger zone, which consists of necrosis and surrounding tissue edema, but there is no more viable tumor tissue. Other interventional procedures that can be performed are portal vein embolization and biliary drainage. As Primarius Mikulic mentioned, portal vein embolization is a procedure that can be performed as an alternative procedure to surgical ligation. Its purpose is to induce the hypertrophy of liver remnant volume. It is most commonly done before major liver resections, such as right or left hepatectomy. The size of the liver remnant volume is estimated on a CT volumetry, and if necessary, portal vein embolization can be performed. On the first picture, this is a pre-procedural CT. The picture in the middle shows embolization of the right portal vein. These are embolic coils and normally patent portal vein and a left branch. And on the last picture, there is a post-procedural CT volumetry, which shows the hypertrophy of left liver lobe and the decrease in size of the right liver lobe. Percutaneous biliary drainage is a palliative procedure. It can be performed when there is a biliary obstruction. It's most commonly caused by the pancreatic carcinoma or cholangiocarcinoma. It is performed when the ERCP was unsuccessful or if it cannot be performed due to several reasons. We do it under ultrasound and fluoroscopic guidance. The peripheral bile duct is punctured and the drainage tube is placed in the common bile duct or, if possible, inside the duodenum. If there is a necessity, we can also place a stent. So at the end, as you could see, interventional radiology has an important role in treatment of primary and secondary liver cancer. Interventional radiology is developing very fast and our materials are becoming more effective and sophisticated. And I believe that only with good cooperation and collaboration with all specialties, we can select the appropriate and the most effective treatment for our patients. Thank you very much.
Thank you very much, Dr. Jurca. And ladies and gentlemen, several years ago, Croatia has been recognized as one of the leading countries for transplantation. Our next presenter, Professor Tajana Filipec-Kanizaj, Head of Department of Gastroenterology at University Hospital Merkur, Zagreb, will in her presentation titled Liver Transplantation for Hepatocellular Carcinoma, Where Do We Stand? Professor Filipec-Kanizaj will tell us where are we today.
Thank you. And good afternoon to everybody. Do you hear me?
Yes.
Okay,
you're welcome.
I would like to give thanks to organizer for this kind invitation. I will speak about liver transplantation for HCC. Where do we stand from the point of view of hepatologists? And we can see on this slide, as it's previously mentioned also, that the incidence of HCC is increasing, it's doubling. And these are the data for United States. We can expect a special increase in number of new diagnosed patients with HCC in group of patients older than 65 in males and in females. Regarding transplantation, HCC is the fastest growing indication for transplantation worldwide, especially in Western countries. And in Croatia, you can see that in last 10 years, the number of patients transplanted with HCC has doubled from 14 to 31%. And on the right part of the slide, you can see that the number of patients, the rate of patients with various diagnoses of liver cirrhosis with HCC is increasing. And for viral hepatitis, more than 70% of our patients which are transplanted have HCC. For NASH, 42%, for alcoholic liver disease, 31%. But liver transplantation and surgical options, as nowadays only curative options, are only options for early and early stage of HCC. And we know that from the point of tumor burden, the benchmark for selection of patients for transplantations are Milan criteria, which are very strict, with one nodule less than 5 centimeters and less than 3 nodules less than 3 centimeters. And we can expect with this criteria that the recurrence after transplantation will be less than 20% and expected recipient survival more than 70%. So our expansion of criteria should be comparable with expected recurrence rate and the survival with these Milan criteria, which are very, very strict. Unfortunately, only 5% of all HCC which are diagnosed are eligible for transplantation in Western countries. This is due to the fact that our criteria for transplantations are very strict on one hand, and on the other hand, which is even more important, that the number of organs that are offered for transplantation are very low in many countries. And if we'll devote all our organs only for HCC patients, we can serve only 25% of all HCC which are diagnosed in various stages of disease. So we are in very, very hard position with transplantation for HCC nowadays. These are the data for New University Hospital Merkur. We know that in Croatia, this is high volume transplant center, also recognized as one of the leading hepatologists hospitals in Croatia, and we have more than 100 patients with HCC every year diagnosed in our hospital. But you can see even with these selected patients, because they are mostly scheduled for surgical options of treatment, that only 1/3 of them are eligible for transplantation because of their disease stage, and 12% for resection. And most of other patients are beyond criteria for transplantation. They're scheduled for oncological therapies or oncological treatment, and every 5th of them is only eligible for palliative care. So our HCCs in Croatia are diagnosed in late stages of their disease. And how to increase the number of patients treated with this curable surgical option? One is to expand and improve criteria for liver transplantation. The other is to improve the donation, and Primarius Mikulic has been speaking about that. And the third is to improve the screening programs and prevent the treatment of liver disease. That I think this is the most important point in treatment of liver diseases, to prevent the development of malignant complications. Regarding expansion of criteria, Primarius Mikulic already stated that there are some hospitals and programs which transplant in expanded criteria with comparable results in 5 years survival, comparable to Milan criteria, and expected recipient survival more than 70%. On the other hand, we have option that we are using in New Rosetta Hospital Merkur in every 5th patient with HCC that are transplanted to downstage to perform neoadjuvant treatment before transplantation, and with local regional therapy to downstage HCC in viable tumor to Milan criteria. And we can see in this slide that the results of patients transplanted after downstaging to Milan in comparison to other HCC patients that are at the beginning in Milan are comparable, even though there is a slightly higher, even though not statistically significant, higher rate of recurrence after transplantation, especially patients that are at explanting finding somehow beyond Milan criteria. Of course, there are concerns with expanding the pool of patients being transplanted beyond Milan criteria, that we will increase the rates of post-transplant recurrence of HCC and possibly decrease the survival of our recipient on one hand. On the other hand, there is a potential to increase the number of patients with other indication not being transplanted or dying on waiting list because of longer waiting time or waiting list if we expand our indications for transplantation in HCC. And we can see that in Croatia, which is a country with high number of donors, we have 12% of patients that are dying on waiting list because of complications of their disease in other indications. So there's a question whether we have space even in high volume centers, in high volume countries with a large number of donors to increase the indications in HCC. What is the professional society position regarding expansion of criteria for transplantation? On left part of the slide, we can see the position paper of European guidelines, and there is no consensus to expand criteria beyond Milan, but they state that patients can be downstage and considered to transplantation in strict criteria if they fulfill Milan criteria with downstaging. American guidelines also are strict in Milan criteria, but they are considered all patients with successful downstaging, also with strict criteria and fulfillment of Milan criteria in evaluation before putting patients on waiting list. In the future, as Primarius Mikulic stated, of course, we should take into account having in mind all these data, not only the tumor size, but also the biology of the tumor, which can be measured by tumor markers, alpha-fetoprotein, and various others that are all investigated nowadays, and also the response to neoadjuvant treatments, which also represent the biology of our tumors. And positive response to the local regional therapy could be biological marker of better prognosis and eligibility for transplantation, even beyond Malin criteria. But as I earlier mentioned, I think that the most important thing is to detect a disease, HCC, in early stages of the disease. And with proper surveillance, we can detect twice as much patients in early stages and improve survival of HCC patients almost twice in comparison to patients that are diagnosed in later stages of the disease. But the problem with surveillance programs, even in pre-COVID time, is that the only less than 20% of our patients with cirrhosis are properly screened. And this is especially prominent in patients with NASH and patients with alcoholic liver disease. And according to this survey, we can see the most important problem in screening are organizational ones, because patients were not scheduled for screening. There is, of course, some cost issues and transportation issues, and of course, the fear of patients about the finding. And in COVID area, according to one of the surveys in many hospitals in Western countries, we can see that almost 81% of hospitals start their screening programs, and half of them their transplant programs in first 3 months of COVID pandemic. So we can expect in the future that the number of patients in advanced stages of disease will be increased, and we should put much effort in order to improve our screening programs and to prevent development of end-stage liver disease and HCC. At the end, I would like to conclude that HCC is one of the fastest growing indications for transplantation worldwide, and especially in European countries and United States. Malin criteria are still benchmark for selection for liver transplantation, but only small proportion of patients fit these strict criteria, and as one of all curable options for treatment of cirrhosis and HCC. And there is no still universal consensus about broadening of those criteria. So it is important to prevent and properly screen patients for HCC, but also to reconsider investigations of further composite criteria for best liver transplant recipient selection. Thank you.
Thank you very much, Professor Filipec-Skaniže. Systematic treatment is important aspect of HCC treatment, and here to tell us more about this is Docent Borislav Belev, head of the Department of Internal Oncology at the UHC Zagreb. Hello.
Hello, everyone. Can you hear me?
Yes.
Just a second.
Okay.
I will share my screen. Do you see my slide?
No. Not yet.
Okay, just a second.
Houston, we have a problem.
Yeah, Houston has a problem, yes. Okay, I'll start again.
Are you on holiday maybe, or?
No, I'm in the hospital.
Okay. Are you ill?
No.
No, you're a doctor.
I'm just working.
Sorry.
Okay, do you see my slide now?
Anyone? No? Okay.
Just a second, I'll try again.
Okay.
First of all, do you see me at all?
Yes.
Okay.
Nice haircut. Glasses.
Yeah. Thank you very much.
Okay.
Do you see now?
Yes, thank you.
Okay, thank you. Just a second. I cannot change slides. This is the problem now. Just a second.
Take your time.
Yeah.
We hope you'll be fast and furious, but no, unfortunately.
Yeah, maybe I cannot change slides. So is it maybe possible? Do you see this first slide?
Yes. We have your presentations, Professor.
Yes. Could you please put my presentation and I'll ask you for changing slides.
Okay, okay. We'll fix it.
Thank
Just
you.
a second.
Thank you.
You must stop sharing screen.
Okay, yes, of course. Here it is.
What a beauty. Okay.
Yeah, thank you once again, and sorry for these technical problems. Hopefully it will be okay now. And Mrs. Terbovic, thank you for a very kind introduction. My talk would be on HCC regarding systemic treatment. Next slide, please. As you could hear so far, it is a huge problem, HCC in the world at the moment. It is the 6th most frequent cancer in the world and the 4th according to the death rate. What tells us a lot about bad biology behind is so-called mortality to incidence ratio, which is about 0.93, which makes this tumor as one of the poorest according prognosis. Most of liver cancers are HCC, about 90%. Next slide, please. And you already heard probably that in Croatia, it is the 10th cancer entity and the 7th cause of cancer death. It is more frequent in males than females. Next slide, please. So what the specificity of HCC is, and which makes treatment more difficult, is the fact that we have actually in the almost 90% of cases two diseases. We have predisposing zinc factor, which is cirrhosis, regardless of the etiopathogenetic factor. So you actually have liver disease and you have oncology entity, and this makes sometimes treatment very, very difficult. So by time we have a loss of liver function at some point, and healthy liver is, is replaced by fibrotic scar tissue, and in that liver that is damaged in that way, we have cancer with all characteristics which are very specific for HCC, as I said. Please, next slide. So today is possible only to treat these patients very, very with much of attention through multidisciplinary approach. In multidisciplinary approach, we have different kinds of physicians specialized in this field, like interventional radiologists, hepatologists, oncologists. And at the same time, we have to take into consideration characteristics of tumor, characteristics and degree of liver damage, preferences of the patients, and many other factors. And of course, availability of the drugs is not the same in the whole world, and it differs from country to country. Please, next slide. So first step is to stage the degree, to determine what is the stage of the degree. Is it resectable or not resectable? Is it operable or not? This is the basis of US classifications of HCC, but in Europe we mostly use Barcelona clinical liver cancer staging system, which in a way unify different characteristics regarding disease and liver characteristics, and makes more accurate our judgment about which treatment would be the optimal one. Please, next slide. So this is BCLC staging, which shows actually that when we talk about systemic treatment, we are in fact focused on advanced disease mostly on BCLC-C stage, but some of the BCLC-B patients, or so-called intermediate stage, are also candidates for systemic treatment when they progress on some local treatments that are available at the moment. Please, next slide. So while the transplantation and resection are reserved for early cancer, locoregional therapies like TACE or TARCERT or radiofrequency ablation are useful in locoregional disease. For advanced disease, we have to use systemic treatments, which improved in the last 10 years. Please, next slide. So on this schema, you can see that there has been very easy, understandable, this rapid progress that has been made in last 10 years. The first treatment that proved advantage comparing to placebo was the SHARP trial in 2007. But of course, we have to keep in mind that many trials have been made in the meantime, and there was no success. There was a combination of TACE with sorafenib. There were trials with other TKIs, and there were no success. It is also the fact with some immunotherapies where we expected much more than we got. But hopefully there will be some changes in the next years. One of the great changes is a combination of immunotherapy and anti-VEGF therapy in a trial in BRAVE 150. Which was a very significant improvement in our view on systemic treatment and in our landscape, treatment landscape. Please, the next slide. So this is a SHARP trial. That was the trial which put sorafenib as globally approved drug for first-line treatment in systemic treatment. As you can see, sorafenib achieved 10.7 months overall survival median, according to placebo less than 8. And it was at that time a very important step forward. Although, as you can see, sorafenib was not compared to active drug, but to placebo, because we didn't have any drug that has been proved to be beneficial in this indication. There was 31% of reduction of death with the treatment of sorafenib. Next slide, please. Another drug which was put on the list as equally efficient was lenvatinib in the study called REFLECT, which was a non-inferiority study. It was compared with sorafenib. And as you can see, these lines are at the same position practically, and lenvatinib had a little bit longer overall survival, but not significant, not statistically significant. So it was proved by this study that lenvatinib was not inferior to sorafenib, and in all recommendations, lenvatinib had the same position in the first-line treatment as sorafenib. Please, next slide. So this is until recently systemic therapies by lines. In the first line, sorafenib and lenvatinib. In the second line, we have several drugs which are active and which makes a difference. These are regorafenib, which is very similar with to sorafenib by its structure, cabozantinib, and anti-VEGF drug ramucirumab, so biologic drug. So all these therapeutic agents have median overall survival of up to 15 months. So there was a need for some more improvement in this field. Please, next slide. So immunotherapy was one of the ideas how to make this improvement. It was also stressed in the first lecture that actually by manipulating this immune response, we can probably inhibit inhibition of T cell activation, and we can do it by anti-PD-1 or anti-PD-L1 drugs or molecules, which are actually antibodies like nivolumab, pembrolizumab, atezolizumab, durvalumab, and avelumab. And from previous time, there was we were aware of anti-CDLH4 as active drugs. The main important molecule here is ipilimumab. They are acting through inhibition of interaction of some molecules on the surface of antigen-presenting cells or cancer cells on the one side, and T cells, immunocompetent cells on the other side. Please, next slide. And especially one combination showed to be very effective. This is a combination of atezolizumab, which promotes T cell activation and disinhibit actually immune response. And on the other side, drug that we are very familiar with because we use it in some other entities. This is bevacizumab, which decreases also angiogenic processes in the tumor and also has some activities that enhance atezolizumab's action. Please, next slide. Next slide, please. Yeah, but this is not all. There are some other immunotherapy combination trials that are still running, in which there are different combinations of not only monoclonal antibodies, but also combination of TKIs and monoclonal antibodies. It will be very interesting to see what are going to be the results of this trial, which are very promising so far. But I will concentrate now on IMbrave 150, which used combination of atezolizumab and bevacizumab. And please, next slide. You've been already told about that, but just let me remind you that it was phase 3 trial for patients with unresectable HCC that had locally advanced or metastatic and or unresectable HCC, and that were treatment naive. They didn't receive any treatment so far. So atezolizumab plus bevacizumab were compared to sorafenib as a standard of care at the moment in the ratio 2:1. This was open label study, and the treatment was received until loss of benefit or unacceptable toxicity. The co-primary endpoints that was very wise to do it in that way was overall survival and progression-free survival according to RECIST criteria. Please, next slide. And what we got by these results, we got significant difference in overall survival. At this slide, it is not written so far, but today we know that median overall survival was actually longer than 19 months in combination in the arm, which combined atezo plus beva, comparing to sorafenib, which showed 13.2 month over median overall survival. So it was statistically very significant. It is visible already graphically, and there was more than 40% of decrease death rate by this combination comparing to sorafenib treatment. Please, next slide. Also, progression-free survival, so survival without progression, was also very significant and very obvious. It was more than 2 months longer for a combination of atezo plus bevacizumab. Next slide, please. What is especially important to stress is that in this trial, for the first time, we got complete response in patients with treated with systemic drugs in HCC. So we had, for the first time, patient that had complete response, and that complete response had a duration that was very, very satisfied. Please, next slide. Regarding side effects, it was completely different comparing to sorafenib. Hypertension and alopecia and some increased ALT and AST, so markers of liver function, were of course more often in combination atezo plus beva, but on the other side we have also hypertension and some other side effects in patients that received sorafenib. And according to this safety profile, this treatment was very good tolerated, even better than sorafenib treatment patients. Please, next slide. And what important is for patients that had incurable disease is the quality of life. We usually have endpoints like overall survival or progression-free survival, but what really matters is quality of life. And when we look at the data that we got from this trial in Brave 150, that is that atezo plus beva delayed the time to deterioration of quality of life compared to sorafenib. Please, next slide. So the landscape is obviously changing. So it is really very important to say that today the standard of treatment should be combination of atezo plus bevacizumab. It was recognized by FDA in the last year, and also later on by European Medical Agency. And of course, for patients that have maybe some contraindications, sorafenib and lenvatinib are valid options that can be used in first line instead. In the second line, we still have regorafenib, cabozantinib, ramucirumab, and in US we have immunotherapy also available in the second drug. Please, next slide. So we have to reconsider what is going to be the schema of treatment of our patients, because in the intermediate stage of disease, for patients that are receiving TACE, it is very, very important to recognize the point of switching TACE to systemic TACE, so local regional treatment to systemic treatment. For patients that cannot tolerate TACE, or for the patients that have contraindications for TACE, systemic treatment now can be even induced earlier in the course of disease. Next slide, please. Please, next slide. And just to conclude, HCC is a great challenge today, but some new treatment options, as you can see, seem to provide better outcomes. Still, we don't have adjuvant treatment proved to be beneficial by clinical trials phase 3, so we have to wait for that so far. Multidisciplinary approach is of great importance in decision-making process, and HCC should be treated, in fact, in expert centers due to complexity of disease and in order to individually make the best approach possible. Thank you very much for your attention.
Thank you very much, Dr. Belev. Together we mentioned we fixed the technical problems.
Yeah.
Thank you very much.
Thank you.
Okay, and now we turn to docent Lucia Virovic-Jukic from Department of Gastroenterology and Hepatology, UHC, Sisters of Mercy, Zagreb. Also Secretary of the Croatian Society of Gastroenterology, to tell us more on emerging science and programs, PIVKA 2. What does it mean? Lucia.
Thank you very much for your kind introduction. Dear ladies and gentlemen, I'm very pleased and privileged to be here on the occasion of the Croatian Liver Week. So I thank the organizers for invitation. My task is to share some new thoughts and insights on screening and surveillance of hepatocellular carcinoma regarding the introduction of new biomarkers with special emphasis to PIVCA or PIVCA-2. So we have heard from previous presentation that hepatocellular carcinoma is a tumor with a very poor prognosis. So screening for HCC is really an imperative for early detection. The studies in China on patients with hepatitis B viral infection have shown that detection of HCC in early stage offers patients better treatment options and improved survival. Also, detection of hepatocellular carcinoma in early stage also offers better treatment options for tumors detected in early stage and improved survival. It found that patients who were screened had 37% reduction in mortality following surveillance for HCC compared to patients who did not have surveillance. The problem is that these results cannot be transferred to our patients, where main risk factor for HCC development is cirrhosis. A large meta-analysis, including 38 studies in more than 10,000 patients with cirrhosis, also found that HCC surveillance was associated with an increase in detection of early-stage hepatocellular carcinoma, and that this surveillance offered patients higher rates of curative treatments. This meta-analysis also showed that patients with cirrhosis who underwent an HCC surveillance had higher survival rates compared with patients who had no surveillance, of course, because they were offered curative treatment options. This is a study from the United States on 374 HCC patients, where 42% of them were detected by screening. And this study also confirmed that screen-detected patients had a significantly higher proportion of early tumors, meaning BCLC stage A, compared to patients who were not screened, and screen-detected patients were also more likely to undergo curative treatment. These patients were also found to have median survival much higher than patients who were not screen-detected but were found incidentally. So now that we have proven that screening and surveillance for HCC offers our patients benefit, it is important to know which patients should be screened. We know of HCC risk factors, and cirrhosis is the most important in Western countries, in Croatia as well, and other risk factors like viral hepatitis, insulin-resistant diabetes mellitus, overweight patients, NAFLD, have also been recognized. So EASL recommends surveillance in patients with cirrhosis in compensated stages, so Child-Pugh stage A and B, and also in patients with stage C who are candidates for liver transplantation. Patients who are not candidates for liver transplantations are usually not screened for HCC because we have no good treatment options for them. EASL also recommends screening for non-cirrhotic HBV patients who are at intermediate or high risk for HCC according to page B criteria, and with a weak grade of recommendation also for patients who are not cirrhotic but have advanced fibrosis or F3 fibrosis based on individual risk assessment. Liver ultrasound is a standard surveillance test for HCC, which is recommended by the majority of, by all major society guidelines. However, ultrasound is not also perfect. So it has a sensitivity of 84% for any stage HCC and 63% for early stage HCC for patients whose major risk factor is hepatitis B. However, the performance of ultrasound in cirrhotic patients is not so good. So we have only 47% sensitivity for early stage HCC in patients with cirrhosis. And these are the patients that we would really like to detect. So less than 50% is the sensitivity of ultrasound for our risk patients. Ultrasound has limitations. It is really dependent on operator, so expertise is really important. We need high quality equipment, which we are all witnesses we very often don't have. And also a number of patient-related factors is important. It especially is important for patients with advanced fibrosis, with advanced cirrhosis, whose nodular liver is a problem to screen, and also obese patients who are now being more increasingly met and screened. So there are many studies trying to find alternative screening methods. Cross-sectional imaging modalities like CT and MRI have proven sensitive. However, they're not so widely available and their cost is a problem. So alternatively, serologic surveillance tests have emerged as a good, not alternative, but addition to ultrasound. A number of possible serum biomarkers for HCC detection have been described and investigated. Some of these are tumor proteins like alpha-fetoprotein, its specific form called L3, des-gamma carboxy protein or PIVKA2, glypican-3 and some other, also some microRNA markers and immune markers. Of all these biomarkers, alpha-fetoprotein is the most commonly used, with a cutoff value of 20 nanograms per milliliter as the value that triggers further evaluation in clinical practice. By itself, alpha-fetoprotein has a sensitivity of 40 to 65%, and for early stage HCC, its sensitivity is unfortunately lower, around 30 to 50%. However, the addition of biomarkers to ultrasound may increase sensitivity of surveillance, as reported in this meta-analysis published 3 years ago in gastroenterology, where we can see that the addition of alpha-fetoprotein to ultrasound actually adds around 50% to sensitivity of ultrasound alone. However, major society guidelines still do not routinely recommend the use of biomarkers for screening of HCC, mostly because of the false positive results, which require further evaluation and increase the cost of HCC screening. The introduction of new biomarkers is being investigated, and PIVKA2 or Croatian PIVKA2, which is short for protein induced by vitamin K absence or antagonist, is actually a form of prothrombin which is synthesized in the absence of vitamin K and is found in tumor cells. It lacks a carboxy group, so it is called a des-gamma carboxy prothrombin or DCP. We have some real-world clinical data on this topic, and researchers have revealed that alpha-fetoprotein combined with PIVKA2 increased the HCC detection rate at about 10 to 20% with a satisfactory sensitivity and specificity. Different studies have looked into a distribution of PIVKA2 among patients with different stages of hepatocellular carcinoma, and also found that it is a good marker for distinguishing HCC against cirrhosis or patients with other liver lesions which are not hepatocellular carcinoma. This is a study from Italy, so it is a study close to us. In patients with hepatocellular carcinoma associated with NAFL or viral hepatitis, where we can see that in patients with HCC, both values of alpha-fetoprotein and PIVKA2 or des-gamma carboxy protein were elevated in patients with HCC. The markers showed good performance, and it was even better if the two markers, HCC and PIVKA2, were combined together. Another Italian group from Torino investigated 3 of the markers, so alpha-fetoprotein, then lens culinaris agglutinin reactive fraction of alpha-fetoprotein, which is called this alpha-fetoprotein L3, and this gamma carboxyprotein or PIVKA2 for HCC detection. And they found that all these markers were useful in detection of HCC. And what is most important, that the combination of these markers was superior to a single biomarker, and that model, which includes these 3 biomarkers together with age and sex, also showed even better performance for HCC detection. And to show the results from Croatia, we have a study published 3 years ago on 32 patients with hepatocellular carcinoma, 31 patients with alcoholic liver cirrhosis compared to 20 healthy volunteers, which also found that Croatian patients had higher levels of marker PIVKA2 in hepatocellular carcinoma patients as compared to alcoholic liver cirrhosis or controls. And the best performance was achieved by the combination of several tested markers. So, according to these results, Croatian Society of Gastroenterology, together with the Croatian Chamber of Medical Biochemists, has proposed to our health insurance fund to introduce PIVKA2 into practice and to actually be able to use this in our everyday clinical practice to screen our patients who are difficult to screen by ultrasound alone. In conclusion, we can see that HCC surveillance in high-risk patients is important for detection of HCC in early stage. It offers our patients more treatment options and survival benefit. Although ultrasound at 6 months intervals is recommended for surveillance, we know from practice that it is suboptimal in some patients, especially patients with advanced cirrhosis. So the addition of serum biomarkers or scores, including these biomarkers, may improve HCC detection and survival. And in the end, please allow me to invite you all to the 9th Congress of the Croatian Society of Gastroenterology with international participation, which will take place in October, and it will be held online. All the information can be found at our website. Thank you very much.
Thank you, Dr. Virovic-Jukic. And in the end of this first part, ladies and gentlemen, let's turn to the connecting point for patients with HCC. For many of them, their battle with HCC starts with their general practitioner. Here to tell us more on their involvement with the liver disease is Jadranka Karuza, with presentation Setting National Priorities for Primary Prevention Role of GP.
Good afternoon for everyone. Thank you, Daniela, for your introduction. I'm here on behalf of the largest Association of Family Doctors in Croatia, KOHOM. I'm thankful for the organizers to inviting us today. I will talk about primary prevention and the role of liver disease and the role of family doctors. Chronic disease prevention in primary care aims to identify individuals at increased risk who can be given tailored disease prevention advice, including lifestyle modifications, disease screening, and/or preventive treatment. Current approaches to chronic disease risk assessment use a combination of factors, including demographics, family history, lifestyle, psychological measurements, and biomarkers, all which are practicing in our everyday work. Informatization has to be on our side and has to work for us. For example, good example of electronic risk calculators that we might use in our everyday practice is Love Your Liver screener made by British Liver Trust. We do not have such calculators in our medical charts in everyday practice. A screening is defined as the application of a diagnostic test to an asymptomatic population in order to detect a disease at a stage when intervention may improve its outcome and natural history. A disease suitable for screening has to be common. The target population must be identified and reached, and a good screening test and an effective therapy must be available. Such disease, when we're talking about chronic liver disease, such disease are hepatitis C, hemochromatosis, and as we heard in the previous presentation, hepatocellular carcinoma. Population screening is not suitable for general practitioners, but target screening with approach of screening only patient at higher risk for a specific disease, and especially opportunistic screening that looks for additional illness in population already complaining to us of medical problems is very suitable for general practitioners. Common chronic causes of liver disease are very well known: hepatitis C and B infection, condition induced by toxins or drugs, especially alcohol, autoimmune chronic liver disease, hereditary disease, non-alcoholic steatohepatitis, and a group of liver disease with no identifiable cause. All of them, as we heard before, are also risk factors for hepatocellular carcinoma. Alcohol consumption as a risk factor, very well known today, has been associated with alcohol hepatitis, fatty infiltration of the liver, accelerated progression of liver disease, higher frequency of cirrhosis, higher incidence of hepatocellular carcinoma, and higher mortality rate. Daily consumption of more than 4 drinks of alcohol, 48 grams, increases the risk of cirrhosis as well as death from other causes. Last year and a half, the world is battling against coronavirus pandemic, and we see people experiencing the fear and uncertainty and anxiety. We can see people losing their loved ones and children not going to school, people losing jobs and facing poverty. And I'm afraid that in the nearby future, we will have pandemic of mental illness and also alcoholism, and thus consequently chronic liver disease. And that is something that we have to have in mind for the future and have to prevent and think about. Medications and supplements. We know that liver is at the central site for the clearance, detoxification, and exertion and activation of most medication, vitamins, and herbal remedies, and thus vulnerable to injury. Population is getting older, chronic not inflammatory disease, and multimorbidity and multi-pharmacy is what we see in our everyday practice. So all medications should be evaluated for toxic effects on the liver. Also, there is a great concern about prescription and over-the-counter pills that people take without medical advice, especially painkillers, and also young adults buying drugs, buying medications or supplements on internet without medical advice or medical knowledge. The World Health Organization recommends at least 3 doses of hepatitis B vaccine for all infants with the first dose given within 24 hours or birth0followed by 2 or 3 additional doses later. Globally, chronic hepatitis B affects approximately 257 million people and contributes to an estimated 7,000 deaths worldwide every day. Strong evidence support vaccination against hepatitis A and B in patients with chronic liver disease because superinfection can result in significant morbidity and mortality. For years now, and especially in last year and a half, we are witnessing the rising star of global anti-vaccine movement and pseudoscience, and I think that every doctor, not only family doctors, must fight them with proper medical information and advice to our patient that is evidence-based. We family doctors are the masters of lifestyle interventions. On the first place, a healthy diet, because non-alcoholic fatty liver disease is one of the most common causes of chronic liver disease in Western countries, leading to high morbidity and mortality, and it's strongly related with healthy diet and with obesity. It represents the hepatic feature of a multi-system disease together with type 2 diabetes, cardiovascular chronic kidney disease, and osteoporosis. Mediterranean diet, frequent herbal tea, and coffee drinking appear to have a protective effect on the liver. Mediterranean diet, as we know, is characterized by a large intake of fruits, vegetables, whole grains, nuts, legumes, fish, and low consumption of red meat with moderate alcohol intake, usually red wine. Physical activity also is important lifestyle intervention because it influences hepatic metabolism, and it's inversely associated with the onset of non-alcoholic fatty liver and steatohepatitis. Physical activity may reduce also the risk of hepatocellular carcinoma. Exercise training induces significant improvement of hepatic and visceral fat accumulation, increased lipid oxidation, and insulin sensitivity, both aerobic and anaerobic training. In our everyday practice, we have to recognize patients with risk factors and also promote preventive measures. Hepatitis A, hand washing, avoiding unclean food and water, vaccination, or immune globulin if exposed or traveling to high-risk countries. For hepatitis C and B, injection drug use, intranasal elite drug use, man-to-man sex, persons on long-term hemodialysis, healthcare and emergency medical and public safety workers after needle stick, sharps, or mucosal exposure to HCV-infected blood, children born to HCV-infected women, recipients of a prior transfusion or organ transplant. And in the end, 9 in 10 cases of liver disease could be prevented. On this picture, there is a definition, European definition of family medicine, its competencies and characteristics. In Croatia, we are struggled with many problems, among them a lack of healthcare professionalists, both nurses and family medicine specialists and trainees, underpayment, and also administrative overload. But the most, the very greatest problem of all, I think, is that healthcare administration do not recognize or even understand the importance of and significance of family medicine, because I think we are on the great place of the healthcare system for prevention of any kind of disease, especially liver disease. So we have to use potential that we already have. Thank you very much.
Thank you very much, Dr. Caruza. I think you mentioned that a sip of coffee is a healthy habit, so let's do it. Ladies and gentlemen, it's time for 15-minute break, coffee break, or this is its possibility to stretch out our muscles or move around. I prefer coffee. So see you after 15 minutes, not 50, 15.
1-5.
1-5.
Yes.
Preko interneta, to nisam skužila, preko Zooma, drugčije.
Pismo da sam kirurg zadnje.
gdje smo mi isključeni, jesmo. Htjela sam reći, ja samo bi molila, ako bi mogli napraviti u jednom trenutku svi skupa zajedničku, jednu family picture, naravno koristit će ove
WHO headquarters in Geneva. We are joined by Dr. Andre Ilbavi, WHO technical officer, and Felipe Reutberg, WHO consultant. So, gentlemen, where are you? Dr. Ilbavi.
Esteemed participants, dear colleagues, I'm Felipe Reutberg, and today I'm pleased to share with you the WHO report on cancer. This first WHO report represents the response to the World Health Assembly 2017, where member states explicitly require WHO to deliver guidance on public health policies to orient cancer control. The document aims to set the agenda for cancer control globally, now and in the decade ahead, and gives reference to the member states. I declare having no conflicts of interest to disclose, and that the opinion here expressed are my own, and the vision do not express the organization's view. As a snapshot for the cancer control globally, please allow me guide you through 3 key findings. The first key finding is that the cancer burden is considerably high, as in high-income countries, 1 out of 2 men has a lifetime risk to develop cancer, whereas this risk in low and middle-income countries is about 1 out of 5. However, bear in mind that the impact in low and middle-income countries is considerably high, while cancer is expected to double in the next 10 years. Also, cancer will represent the leading cause of premature deaths for all countries in the upcoming decades. The rise of cancer burden also affects Croatia. And here, I kindly ask you to pause and note the trend for incidence rates for all cancer increased by 9.2% and mortality by 18.2% until 2040. Specifically for liver cancer, an important increase in incidence of 15.8% is expected until 2040 and might pose even more challenge to liver cancer control. Please note that more than a half of patients exhibit late-stage disease at diagnosis. As a consequence, impact on mortality ratio and the need for service and the respective costs. As a key finding too, progress is inequitable and insufficient to reach United Nations Sustainable Development Targets to reduce premature mortality by 1/3 until 2030. In this regard, the blue curve in the graphic shows that high-income countries are performing better than low-income countries in terms of health outcomes for cancer patients, the latter far from reaching the targets. However, not all high-income countries perform equally well, as you see here in the graphic extracted from the last cancer country profile for Croatia. Nonetheless, the red dashed curve slope is projecting the direction of SDG targets. This progress will improve even more due to the recently launched NCCP and the priority interventions policies and investments to come for Croatia. As a key finding 3, are we allocating enough funds or investing right in cancer? The answer is no for the majority of countries, especially for low and middle income countries. Taking NCCP as a reference in a global analysis, only 9% describe fund allocation for cancer control. Not only budget allocation, but also efficiency. In other words, not only improving sufficient money, but investing in cancer care to obtain the greater health benefit for money spent, which in other words also means value for money. When we look at the treatment, the data shows that only a few cancer medicines from WHO essential medicines list are covered by countries, challenging cancer patients' access to effective treatment and probably incurring in financial toxicity for the patients and households. But all high-income countries invest similarly. Regardless of non-specific data for cancer expenditures, this graphic shows that healthcare expenditures varies considerably among high-income countries, including Croatia. So once again, we reinforce the importance of budget allocation and expenditure efficiency aligned with the burden of disease, the healthcare capacity, and the feasible considerations to prioritize investment. Overall, as the three findings described, the increased burden of cancer, the inequalities in cancer care, and the lack of adequate investments, they support the need for WHO-reported cancer as a reference for defining priorities and investing wisely to reach the Sustainable Development Goals in the next 10 years. So setting the agenda for the next 10 years. As for the next decade agenda, the three pillars you see here for governments to improve cancer control are related also to these main recommendations. I would highlight some, as for example, in identifying evidence-based priorities that can be financed. And according to investing wisely, to invest the priority in WHO best buys for primary prevention and prioritizing early diagnosis with target stage shift of 20%. Importantly, we should optimize workforce and access to medicines and health products as a cornerstone for providing cancer care for all. So what we expect to achieve in the decades ahead? Quality, sustainability, and equity are the three major areas that require our attention and effort to respond to the major challenges. Firstly, how to reduce the impact of nearly 1 to 3 million deaths related to low quality of cancer care by training and providing standards of care. 2, how to address sustainability and reduce not only the rising cost of cancer, but the financial toxicity for patients and households by promoting impact analysis and priority settings and the pricing approach. And 3rd, how to effectively address inclusive and tailored strategies through the benefit package adoption. Please find here the WHO Cancer Control Country Profile 2020 for Croatia. Every country has a cancer country profile that might serve as a guidance for governance, offering input for action according to the identified priorities and opportunities for engagement with the stakeholders. This provides the member states the benchmark for burden of cancer, health system capacity with special considerations for workforce as a main driver, and a capacity to address the response. And here, I pause to connect not only with stakeholders, but with you, healthcare provider, that as a clinician, ask yourself how agenda for liver cancer can connect and integrate with the NCDs. As you see, primary-based interventions with high impact, low cost, and feasible, also named best buys, plays a major role to reduce the liver cancer burden. Hepatitis B birth vaccination rates already achieve 97% in Croatia. So, in addition, public health policies addressing other prevalence risk might not only translate in a major impact, as such as alcohol consumption, diet policies, and physical activities. So, also relevant to flag diagnosis and treatment as potential interventions where access to timely quality diagnosis and treatment might influence cancer patients' outcome. As an important achievement for cancer control agenda, let's recognize and celebrate the value of recently launched Croatia National Cancer Control Plan 2020 and its comprehensive content. Markedly, the plan is designed to provide evidence-based orientation for incidence and mortality reduction towards well-defined goals. Also, the plan has been a comprehensive analysis for both health and economic impact, allowing to define the benefit for investment and providing comprehensive and meaningful economic analysis, which improves sustainability. Overall, I ask you to pay attention that has been included the 10 most relevant and prevalent tumor sites in Croatia. You might see the health benefit impact and economic impact with well-defined goals and targets for monitoring and for reaching in this 11 years. And please, again, for liver cancer in these 11 years, you might find the incidence reduction of 9%, which means 542 cases, and life years gained with the NCCP adoption, about 5,073 life years gained with cost-effective interventions, which also reinforced the importance of quality and also value-based interventions. As we envision the decade ahead, we also should reflect on the impact of COVID-19 posed for cancer care and the healthcare agenda. This slide gives an example of points where the health system has been challenged, severely stressed by the COVID pandemic, and must be recognized and monitored for HCCP implementation. Lastly, I ask you to pay attention for this specific article where cost effectiveness analysis are trying to define which is the best approach for a given specific cancer management, which is a late stage hepatocarcinoma, if radiotherapy with yttrium or sorafenib. But again, this intervention should be taken only into consideration when the feasibility is possible and considering all the current financial perspectives for a given country and adapted to every country needs and also for the current capacity. In conclusion, cancer burden is rapidly rising, straining individuals and societies and also the families. The response is inequitable and insufficient, and also are the funds and the investment should be better addressed in terms of improved efficiency for investment. Access is limited by health system capacity and compounded by failure to set value for money. Defining value for cancer intervention is critical and will help justifying investments for all stakeholders. So the investment and the plan should be taken into consideration by the scope of universal health coverage as a foundation for response, setting priorities, prioritizing coverage, and evaluating the efficiency and ensuring quality for the cancer care. Thank you for your attention.
Thank you, doctors. And now we turn to the often skipped over aspect, of liver disease, mental health. And in past year, COVID-19 pandemic has shown us the dangers of ignoring these important areas. More on this in presentation titled Impact of COVID-19 on Mental Health and Viral Infection Perception. Please join me in welcoming Professor Daniela Štimac-Grbić from European Public Health Association. Professor Štimac-Grbić is also head of the Department for Mental Health and Addiction Prevention in Croatia Institute of Public Health. Daniela.
Thank you, Daniela, and it is a pleasure and honor to be here today. So let's talk about mental health, something different, but mental health is really in threat during the COVID-19 pandemic. So I will start with the definition. Mental health is defined as a state of well-being in which every individual realize their own potential, can cope with the normal stress of life, can work productively and fruitfully, and is able to make a contribution to her or his community. According to World Health Organization definition of health, is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So according to these definitions, we really can ask ourselves, is it possible to be healthy in a pandemic? Because we are facing threats to all of these components of health, physical, mental, and social. Fear, worry, and stress are normal responsive to the perceived or actual threats. They occur when we are faced with uncertainty or the unknown. It is therefore normal for us and understandable that people experience fear in the context of COVID-19 pandemic. So we are facing the restricted movements, we are facing lockdowns, we are facing limited social contacts. It is something that really increases stress in our life. We are living now in the so-called new normal or in new reality. A lot of us work from home, some people facing unemployment, homeschooling of children, lack of physical contact with other family members, with friends and colleagues, impossibility to travel. That's why also the World Health Organization recognized that mental health should be priority in the times of pandemic. And the World Health Organization conduct a survey in 130 countries and provide the first global data showing the devastating impact of COVID-19 pandemic, access to mental health services, and highlights the urgent need for increased investment in mental health care. The COVID-19 pandemic has disrupted or halted the work of mental health services in 93% of countries around the world, while demands for mental health servicing are growing. A pandemic of mental disorders is expected after the COVID-19 pandemic, and we should be prepared for that. That's why the director of World Health Organization also said that the good mental health is absolutely crucial for the overall health and well-being of the population. COVID-19 has cut off basic mental health services around the world at the time when they are most needed. World leaders must act quickly and decisively to invest more in life-saving mental health programs during and after a pandemic. The different people react different to different stressors. Also, a response to threats caused by COVID pandemics will be caused by the individual's characteristic, like uncertainty, intolerance, tolerance to stress, level of anxiety in the person, or perception of disease vulnerability. Even previous researches showed that during epidemics, any epidemics, the number of people whose mental health is at risk is generally higher than the number of people affected by the infection. So patients infected with COVID-19 or suspected for infection may experience intense emotional reactions to the stress and behavioral changes such as fear, isolation, loneliness, anxiety, insomnia, or anger. It is important to incorporate public health mental health policies into pandemic response strategies. Mental health professionals, such as psychologists, psychiatrists, and social workers, must be at the forefront of the battlefield and play a leading role in the emergency planning and management of the teams. COVID-19 is threatening from the challenging from the psychiatric perspective, as well as it is from the epidemiological perspective. So just with synchronized public health interventions in stopping the pandemic and protecting mental health, the way that COVID-19 is changing the world can be even better. So what is very important is to recognize some especially vulnerable groups during the pandemic, and those are older population, children, health professionals, and people who are already in risk to develop some serious mental disorders. When we speak about older population, mental health problems are common in older adults, and the prevalence of depression symptoms, even in the time without pandemic, in this population is more than 23%. A particular problem is related to insufficiency or inaccurate data and information for the older population about epidemiological measures and about situation in the pandemic. And also social isolation in older population is increasing during pandemic, and social isolation is something that is risk in the time without a pandemic also for the older population. So epidemiological measures, especially lockdowns, lockdowns in the nursing homes are something that also pose ethical questions, and epidemiological measures and the human rights of the elderly should be considered by the World Health leaders also. When we speak about children, in children and adolescents for healthy growing up, the most important are social connection, peer support, presence of parents in the child life. And now we are facing something that is totally opposite of this. Social isolation, absence from school, reducing socializing, reduced physical contact. We have increased reported child abuse rate. Parents and children live with increased stress. For many, the economic impact of the crisis increased parental stress, abuse and violence against children also increased. And continuous development of social and emotional skill is something that should be integrated, especially in the school curriculum during the pandemic and the post-pandemic period, and also even in the online learning. So also it is very important to implement psychological help to the families that are already recognized at as a risk for the mental health disabilities. Health workers, the special category in risk, they are facing with increased stress, burnout during the pandemic, fear of infection for themselves or their families. They feel anxiety due to insufficient knowledge of the virus. They feel incompetent in some point of their work. Because of that, feeling helpless sometimes. And of course, they are facing a lot of moral doubts about pandemic because of lack of knowledge about this virus. They have doubts about treatment, about epidemiological measures, about vaccination, about all social measures that we are facing with. People with mental disorders, of course, they are especially at higher risk in this period. We have a rise in anxiety, depression, high rates of post-traumatic stress disorder, insomnia. At the same time, physical distances has reduced the availability of many family, social, and psychiatric benefits. People with serious mental illness and associated socioeconomic risk are particularly at risk of the direct and indirect effect of the pandemic. So different countries have different responses to the pandemic and to pandemic threat for mental health. Most of the countries included Croatia, increase telephone psychological support. In Croatia, we have more than 50 open lines for psychological support for infected people or for people who feel stressed during the lockdown, during the epidemiological measures. We have to remember that we have 2 earthquakes in Croatia, so the rate of stress is even higher. Also, something that increased during the pandemic period is telemedicine interventions, and this is something that will grow and increase even in post pandemic era. Very important during this time is peer support. So for people with acute problems, people who are not so much connected in their community, who have not available all the health services, it is very important that have organized a peer support. Globally, users and small independent support initiatives have been shown to mobilize very, very quickly to provide immediate assistance during a pandemic. So these community support services responded proactively to COVID-19 differently and faster than conventional health services. A pandemic is actually opportunity for decision makers to recognize them, to recognize user organizations, civil association, as well as very important providers of healthcare in protection of mental health. And we have to just remember that users' peer support services should supplement but not replace the usual mental health care system. Also, telemedicine is something that really increase and develop during time of pandemic, but we have to face with some questions the issue of availability. Not everyone has the internet, not everyone knows how to use the new technologies, and it is a possibility for increasing health inequalities. We in the Croatian Institute of Public Health, in cooperation with the psychiatrists from the Clinical Hospital Vrapče, published a package of recommendations for maintaining mental health by combating the negative effects of anxiety and stress. You can find it at the web pages of the Croatian Institute of Public Health, of the Clinical Hospital Vrapče, County Institutes of Public Health, and those are some self-help recommendations, because the level of stress, especially in those areas such as Zagreb and Sisa County, are very high, not just during the pandemic, but because of the earthquakes that we faced. And one of the recommendations is for listening to music to relax and improve sleep. And this is something that I would like to finish with. So my recommendation for relaxation after this conference is also at this playlist. So thank you very much for your attention.
Thank you very much, Professor Štimac-Grbić. Let's start the music play and stop talking. Another healthy habit. But our next topic is relating to tomorrow's marking of International NASH Day and the growing problem fatty liver present to our society. Professor Sanja Music-Milanovic from Croatian Institute of Public Health is the national focal point in several health promotion topics, including the EU Physical Activity Focal Points Network and the expert group, Health Enhancing Physical Activity. She is the national technical focal point of WHO for promoting health throughout the life courses, as well as national technical focal point of WHO for nutrition. Professor Music-Milanovic is here to talk to us about prioritizing health promotion, building an environment that promotes health and encourages citizens to make healthy choices. Okay, I'm tired. Choices. Okay, I done it.
Hello to everybody. Good afternoon, and thank you. At the first place, I would like to thank the organizers for inviting me to this Congress. It's an honor. And last year, we've talked about quite a strong, significant association between obesity, and that's a topic that I'm going to talk about today, between obesity and non-alcoholic fat liver disease. And what happened in the meantime? COVID-19 pandemic happened in the meantime, and we already had, before COVID-19, we already have pandemic of obesity worldwide. So basically, we are now talking about, when talking about obesity issue, we are talking about so-called syndemic, which is synergy of two pandemics, pandemic of obesity and pandemic of COVID-19. And the really important thing that happened during this COVID that we realized that obesity, unhealthy body mass index, isn't only the common denominator for the five main diseases these days, non-communicable diseases, but also for communicable diseases as well. So I will try under this title to speak about two things. The first one is connection, association, two-way association between unhealthy body mass index and COVID-19, and then about another thing, which is a direct intervention in the environment to tackle this issue. Just for the beginning, we all heard about body mass index as a reference measure for the categories of nutritional status. It's not the best one. The scientists are arguing quite a lot about it, but it's the best one that we have so far. Today I will talk about overweight, which is body mass index 25 kilo per square meter or higher, and it includes obesity as well. Sorry about this, but after all, I'm an epidemiologist, so I need to have at least one slide with the figures. It's gonna be quick and I hope painless. I will compare some figures of Croatia with a global one. So at this point, in this moment, globally speaking, there is something like 13% of adults with obesity, body mass index 30 or higher, and 9% of children. In Croatia, almost double of adults and children with these figures, with this issue. OECD report, the report of the countries that merged based on some financial and economical support and issues, give a report for the next 30, some projections for the next 30 years until 2050. Really interesting projections. And it says that globally speaking, 722 million of chronic non-communicable diseases will happen only and exclusively due to the obesity. And in Croatia, by year 2050, we can expect 500,000 non-communicable diseases that we can avoid if nobody is only obese, not overweight, only obese, only with a BMI 30 or higher. And ever since we have census and ever since we know how to calculate life expectancy, actually this is the first disease. And I'm always talking about disease because according to the international classification of diseases, overweight and obesity are diseases, E65 and E66, under the title E65 and E66. So this is a disease, not just a risk factor. This is the first disease that is going to shorten our longevity, 2.7 years by 2050 globally, and a bit more, 3.5 years in Croatia, if we don't stop and increase, as so far we didn't. It costs in Croatia 6.6% of the whole budget, the whole health budget. We are spending on something that is connected with obesity, even more in the world. And something that is connected, and I already said, syndemic, which is synergy of those two already, one of them already existed, and in the last year and a half, we have another pandemic. And they are connected. There are two-way of connection between unhealthy BMI and COVID-19. I will start with the influence of unhealthy BMI on this new COVID-19 disease and pandemic. Based on the paper that is published in Lancet on really impressive sample size, almost 7 million adults, it's very clear to see that there is an association, a significant one, of course, highly significant association between body mass, higher body mass index and COVID-19 admission to the hospital, admission to the intensive care unit, and deaths due to COVID-19. There is really, really interesting atlas published about connection between COVID-19 and obesity, published on the World Obesity Day. It was March the 4th this year. World Obesity Federation published this atlas. And it shows that if countries have more than 50% of adults with overweight and obesity, and for example, Croatia has 60% of adults, there is 15 times higher rate of deaths due to the COVID-19 in comparison to the countries that have less than 50% of adults with overweight and obesity. More specifically, 66.8 per 100,000 inhabitants in comparison to 4.5, quite a big difference. But there is another association as well. COVID-19 made an influence on unhealthy BMI that I think that we are now aware of, and it has been published already in really important journal, and I will try to explain this slide step by step. It was published in International Journal of Environment Research and Public Health. Well, due to the COVID-19, we had these confinement measures. So we spent more and more time at home. I don't know, we worked from home, school was online, gyms were closed, some outdoor activities were limited, even some shops were closed. So we had some extra time that we needed to spend at home. And what happened at home? Sedentary behavior lifestyle happened at home, of course. And some changes in dietary behaviors happened at home. For example, now we know, and it's already been published, that the more frequency of snacking happened. But something even more interesting happened, some kind of desire to cook. And especially, believe it or not, to knead. And due to that, what happened? More homemade sweets, more pizzas, more bread, and so on and so on. And we are talking about only about food with high glycemic index. And in addition, due to the inability to procure fresh fruit and vegetables, we actually somehow tended to buy some shelf life products. And of course, shelf life products are products with high glycemic index as well. And all together, of course, lead to weight gain. And nevertheless, for the end, don't forget that healthcare professionals were diverted from, for example, obesity issue to dealing with COVID-19. And not only the obesity prevention, many other things have been postponed for some other time. And I think that the time came or is coming, but we have quite a bigger problem than we used to have. There is only one paper that I found so far that measure an increase of body mass index in adult population in Germany. They found that in the last year, the body mass index increased among adults for 1 kilo per square meter. And just for comparison, in the last 50 years, it increased for 0.4 to 0.5 kilos per square meter in decade, in 10 years. So I think that now we are dealing with really big problem. So we have a vaccine. We feel relaxed, but no, we cannot feel relaxed because now we are quite aware that body mass index, unhealthy body mass index, is not only a risk factor for non-communicable diseases, but for communicable diseases as well. And here are some plots that are explaining the association, significant association between having high body mass index and, for example, influenza, different types of influenza. So we definitely had to deal with obesity prevention, but now it's even more urgent, and the roots of obesity run really, really deep. It's not just, you know, on individual level. It used to be like that in the 70s, like you more take, there is a high intake that outtake. It's like a balance between nutrition and physical activity. It's you know, on individual level. But actually, the main problem is obesogenic environment, because the environment is the one that are forcing us to eat and not to move. So here, I'd like to share with you a map of interactions between nutrition and physical activity in the environment. There are so many, you know, ways of interaction. It's not easy to tackle. And if we want to make a population-based health promotion program, we have to work only and exclusively on in the environment, to change an environment, to make, as somebody said a few minutes ago, healthy choices, easy choices. Actually, this paper is published a few months ago, but back in 2011, 10 years ago, there was a really important paper in Lancet that says that the increasing weight of people worldwide is the result of a normal response by a normal people to an abnormal environment that we are living in. And in the National Institute of Public Health, when you see these so-called butterflies, I would say, but maybe we can call them leaves, within our national health promotion program, we are dealing with those ways that you can see. Healthy Living Project has 5 main components, and each of them is trying not only to teach somebody something, but to make a direct intervention in the environment. But we need, if we want to halt the race, and WHO said, there are 9 global targets that WHO made. And for this one, they don't expect a decrease, just halt the race. They're satisfied with halting the race of obesity. And we cannot do everything by ourselves. Like 15 of us are doing a national project. And I think that we are trying, you know, to change the environment quite a lot. But it's very, very difficult, and we need everybody, and we need more people to get involved. And most probably you heard about corporate social responsibility and health impact assessment. And let me make a proposal here for everybody to think about obesity impact assessment. I will give you an example. For each 10% of increase in investment in IT sector, and they invest a lot, we now know, and it's been calculated, that there is an increase of 1.4% of obesity. So I would like actually to ask every single stakeholder, every single industry to think about that and to think about impact on health, on obesity when they are developing something. Well, thank you very much.
Thank you to Professor Sanja Music-Milanovic. And dear participants, we are going on. Our next presenter is a clinical dietitian, epidemiologist, and researcher in nutrition epidemiology. Professor Shirazel Berzagi is the head of School of Public Health Faculty of Social Welfare and Health Sciences, University of Haifa, and the Tel Aviv Medical Center, Department of Gastroenterology and Hepatology, and also a member of EASL, Policy Public Health Committee. Are you ready?
Hello, I'm very happy to give this talk on the lifestyle approach to a healthy liver. So non-alcoholic fatty liver disease is actually a disease that is mostly driven by obesity. And here we can see the strong correlation between obesity in different countries and the prevalence of non-alcoholic fatty liver disease. So clearly, if we want to treat NAFLD, we need to treat obesity, but we also need to treat other things like dietary composition, which is also very important for liver health. And this will be a major topic in my talk. So if I need to give you now the take-home message right at the beginning of my talk, I can tell you that in every stage of liver disease, in every stage of non-alcoholic fatty liver disease and cirrhosis and even liver cancer, there is something that we can do to improve liver health. So if we have steatosis, and even if we have NASH, which is the more inflammatory state, the more advanced stage of NAFLD, and even if we have fibrosis, if we do diet, if we have weight reduction and change dietary composition to a more healthier diet, and if we increase physical activity, then we get significant improvement in steatosis, NASH, and fibrosis. And even if we have more advanced liver disease like liver cirrhosis, if we have a healthy lifestyle, we may be able to prevent progression to liver cancer, to hepatocellular carcinoma. So in my talk, I will show you the evidence for these benefits which diet can lead to. So let's start with weight reduction. In this meta-analysis, we can see very nicely the improvement in liver damage that is caused by weight reduction. If we have a significant weight reduction, then we can have reduced steatosis, reduced ALT level, serum ALT level, reduced NASH, non-alcoholic steatohepatitis, meaning reduced inflammation as shown by liver biopsy. And we can even have reduced fibrosis, although it's not consistently shown in all studies. So in studies with liver biopsy, it is not significant. But if we look at studies testing liver fibrosis by liver stiffness by FibroScan, we can see significant reduction in liver stiffness caused by weight reduction. So how much weight reduction should we have? This study shows us very nicely. In this study, there was about a year of lifestyle intervention, including diet, physical activity, behavioral therapy, and they had repeated liver biopsies. And we considered patients who had a reduction of 5% of their initial body weight had an improvement in all aspects of non-alcoholic fatty liver disease, in all features of liver disease, NASH, fibrosis, and steatosis. If you have a greater weight reduction, 7% at least, or 10% at least, then the improvements are greater. It means that the larger percentage of the patients will benefit significant improvement in all features of NAFLD. So if you have at least 10% weight reduction, all patients will have improved steatosis, 81% will have remission of fibrosis, regression of fibrosis by at least one stage, and 90% will have NASH resolution. However, it's very difficult to achieve 10% weight reduction for some of the patients and to keep it in the long term. So please remember that even 5% weight reduction is beneficial. And this study shows us which type of diet should we choose. So they compared low-fat diet with and without physical activity and Mediterranean diet with and without physical activity. And they show us that if we have the diet of Mediterranean low-carb diet plus physical activity, then you get the greatest reduction in the amount of liver fat, 80% reduction in the amount of liver fat, where the least improvement was in the low-fat diet without physical activity. There was an improvement, 34% reduction, but the least improvement. So if you want to have the best achievement, combine Mediterranean diet with low-carb diet with physical activity, and you will get a great improvement in the amount of steatosis. What should we offer to the lean patient? Lean patient can also benefit, or normal weight patient can also benefit from a modest weight reduction, like 5% from initial body weight. They do have increased abdominal obesity as compared to people in normal weight without liver fat, so they would benefit from weight reduction because it would lead to reduced abdominal obesity. They would also benefit from a healthier diet, lower consumption of sugar, especially sugar sweetened beverages, and a reduced consumption of saturated fat and cholesterol, which are also related to fatty liver, also in normal weight patients. And if we want to improve our diet, we need to reduce the consumption of ultra-processed food and drinks, as you can see here in the picture below. This is a very highly industrial processed food, which is designed to be very tasty and tempting, but it's very unhealthy, and it contains a lot of sugar and saturated fat and other unhealthy compounds. In fact, ultra-processed food is the major source of added sugar in a Western diet. And amazingly, 50 to 60% of the calories in many Western countries are actually contributed by ultra-processed foods. So we want to reduce this consumption of these foods, and we want to increase the consumption of unprocessed or minimally processed foods like the Mediterranean diet. How would you recognize ultra-processed foods? It's quite easy. You look at the ingredient list, and if the list is very long and complex, then usually it's an ultra-processed food. And if you see in this list all kind of ingredients that you don't use in your kitchen, then you know it's an ultra-processed food. And ultra-processed food is actually a formulation of food substances modified by chemical processes by the food industry. It contains cosmetic additives to improve the flavor and colors. And it's designed to be very tasty, as I said, to stimulate overconsumption of this food and overconsumption of calories. And if we want to be more specific, we can look within the ultra-processed food and the processed meats. So we have shown that overconsumption of red meat and processed meat is directly related with non-alcoholic fatty liver disease, and is also related with insulin resistance, which is a major factor in the pathogenesis of fatty liver disease. If you cook the meat in unhealthy methods like frying or preparing it to a level of very well done, it is also harmful and related with insulin resistance. So don't eat processed meat, eat red meat in a small amount, and don't fry it or prepare it to a level of very well done, because it is related also with liver damage. And this is also supported in this study, showing that red and processed meat are related with NAFLD with and without cirrhosis. Overconsumption of cholesterol is related with NAFLD with cirrhosis. And in contrast, consumption of fiber is protective from liver disease. Saturated fat is unhealthy. People provided for 3 weeks with saturated fat develop liver fat. Also, if they eat a lot of sugar, they develop liver fat, but they don't develop liver fat if they have unsaturated fat. So the type of fat we eat is very important. Try to reduce the consumption of saturated fat and increase the consumption of unsaturated fat. And consumption of high-fat dairy products, which are rich in saturated fat, is also related with liver cancer, with hepatocellular carcinoma. So if you consume a lot of high-fat dairy products or butter, you have increased risk of having liver cancer. But if you consume low-fat dairy products, which are low in saturated fat, then you don't have increased risk. So the amount of fat is really important. And the good news that if you reduce the amount of sugar consumed in the diet of children who usually consume a lot of sugar, so you take them and you provide them with diet, with a low sugar diet for 8 weeks, then you see very significant improvements in the amount of liver fat and in the levels of ALT in the intervention arm as compared to the controls who did not do any low sugar diet. So low sugar diet helps very quickly. And high sugar diet is not only related with the amount of liver fat, it is also related with steatohepatitis, with the more advanced form of NAFLD among children. Children who consume a lot of sugar have increased risk to have NASH. So not surprisingly, that the American Academy of Pediatrics strongly recommends to reduce sugar consumption among children. And they stated that the excess consumption of added sugar, especially from sugary drinks, poses health threats to children and adolescents. So obviously we need to start to reduce the amount of sugar consumed starting from childhood. And this study shows us that we should start very early, because infants at the age of 1 year who consume at least 2 soft drinks per day, including fruit juice, have 3-fold increased risk to develop NAFLD at the age of 10. So we should start very early with sugar reduction. So fruits, I'm always asked about fruits. We can have fruits, although they contain sugar, but if we have a reasonable amount of fruit, then it's okay to have them. They have a lot of important ingredients like antioxidants and vitamin and fiber. So if you have like 2 or 3 fruits per day, portions of fruits per day, it was not demonstrated to be related with any harmful liver effect, but just remember to consume the whole fruit and not a fruit juice. If you want to know what a healthy diet looks like, you need to look at this very famous Lancet paper showing how should a healthy diet look like. And if we all globally eat this diet, then we would save each year 11 million adults death globally. So you can see a lot of fruits and vegetables, whole grain foods, plant source protein, like legumes, and very small amount of red meat, and you don't see processed meat at all, and you don't see sugar, and you don't see soft drinks. So this is how a diet should look like if you want to be healthy generally, and also if you want to have a healthy liver. And if I need to summarize all the do and don't do things to keep your liver healthy, in terms of treating non-alcoholic fatty liver disease, but also in terms of prevention of liver cancer, prevention of hepatocellular carcinoma, then this slide shows us that we should increase the consumption of Mediterranean diet, including fruits, vegetables, fish, low-fat dairy products, olive oil. Obviously, we should increase physical activity, which is also protective, and even drink coffee, which is protective from liver cancer in several studies. In parallel, we should reduce the consumption of the so-called bad foods like processed meat, red meat, high-fat dairy, butter, sugar, soft drinks. And we also should avoid smoking, because smoking is also related with more advanced fibrosis and with liver cancer. So this slide kind of gives you the entire dietary advice to keep if you want to keep your liver healthy. And because nutrition and obesity are so strongly related with NAFLD, there is a published policy statement on obesity and nutrition and its importance in non-alcoholic fatty liver disease. And I strongly recommend to read this policy statement and to get some idea regarding the individual diet of the patient, but also to get some idea about the policy that needs to be done to help the patients to keep a healthier diet. So there's a lot of changes to need to be done, like formulation of food, reduction of the amount of sugar in different food, food labeling, education, and reduction of advertising of harmful foods, and working together with the industry to improve the ingredients within the ultra-processed food to make it less harmful. And with this, I would like to thank you for listening. It was a pleasure to give this talk. Thank you.
Thank you, Professor Zelberzagi. After your presentation, I'm really hungry, healthy and unhealthy. No, now we move on to political aspects of the liver management. We are joined by the member of European Parliament, Tomislav Sokol, who will tell us more on EU for Health 2021. HCV elimination will reduce cancer. Mr. Sokol?
I'm here. Thank you very much. I hope you can hear me and see me.
Yeah.
From Strasbourg. So thank you very much again. Thank you for inviting me to speak at this very important event. And I especially think that these kinds of events are important to shift focus more from COVID-19, which has taken up all the public space and public debate now about healthcare, to really focus on non-communicable diseases, which are here to stay and which will definitely be very, very important in the years the COVID-19 pandemic has ceased. So first, what I would like to say about the European Union, that is my topic today. So what European Union can do and what it is doing is that we have to be realistic about what EU can do, because first and foremost is that healthcare is primary and national competence. So member states of the EU are in charge of financing, organizing, and delivering healthcare on their territory, and the European Union is there only to help, to provide assistance to member states who are still primarily in charge of their healthcare systems. So European Union cannot harmonize, cannot force certain solutions upon member states, but it can help them resolve certain issues that evolve, and especially those issues which member states cannot resolve by themselves. So if there are problems where common action is required, then EU has a role to play. And one of these areas, of course, is COVID-19 pandemic, but also non-communicable diseases and other communicable diseases as well. So when we speak about European Union and liver disease, and especially hepatitis in general, what I would like to say is that even though, as I said, primary competence to regulate healthcare are on national level, EU is now starting to shape new systematic healthcare policy on the common level. So I think this is very important. So for the first time, healthcare has become one of the priorities of the EU, and we have more and more actions on the European level, which is being organized as we speak. So I will just mention a few crucial instruments which I think are very important in this sense. So first is the EU for Health program. So this is our topic for today. So EU for Health program is the new financial instrument, a new financial source in the European budget, which is the first self-standing EU fund for financing healthcare. And I think this is something which is very important, because in the previous 7-year budgetary period from 2014 to 2020, there was the health program. The previous health program was part of the European Social Fund, and it only amounted to 450 million euros. So now, so this was a feeble amount with which you couldn't really do much. So unlike the new EU for Health program, which European Parliament was fighting to have in its present format, and this EU for Health program is now 12 times larger than the previous health program for the previous 7 years. So the current EU for Health program for the next 7 years will be amounts to 5.1 billion euros. And so this is much more than ever before, and it shows that really healthcare has become one of the priorities of the European Union. So the EU for Health program has 4 general goals: to improve and foster health in the Union, and here the most important focus is on disease prevention and health promotion; to tackle cross-border health threats; to improve medicinal products, medical devices, and crisis-relevant products, and especially to make expensive medicines, more affordable for the patients; and to strengthen the health systems, their resilience and resource efficiency. So these are the 4 overall goals of the EU for Health program. And this shows what will be the funding priorities in the next 7-year period. And of course, what is very important is that that prevention of disease is the first goal mentioned in the EU for Health program, and this will definitely be one of the main priorities of the EU for the next several years. So the second important, so this is the first important instrument. The second important European Union instrument is the EU Beating Cancer Plan. So what I would like to mention is the fact that that even during the electoral campaign for 2019 European elections, Beating Cancer Plan was made a priority during the electoral campaign by the European People's Party, and this shift of priority towards beating cancer has resulted in the Europe's Beating Cancer Plan published by the Commission 4 months ago, but also in the creation of the European Parliament's Special Committee on Beating Cancer. And I'm the member of this committee, and this committee is due to deliver its report on the Europe's Beating Cancer Plan of July. And I think so. Here the Parliament will make its own recommendations, suggestions, and proposals on how to improve the Europe's Beating Cancer Plan and how to make it better than it is now. But what I would like to mention here is that Europe's Beating Cancer Plan is very important, and it is also connected to the topic of today's conference, and that with hepatitis, because its main novelty, the main novelty of this plan is that it presents a systematic instrument to beat cancer. Why? Because it does not only focus on healthcare treatment, on cancer treatment, which is usually the emphasis, the priority of all the plans, strategies, programs, etc., but that it actually focuses on everything from prevention, early detection and diagnosis, treatment, and afterlife for cancer survivors. So this is the first systematic program which really shifts the focus from treatment, which is obviously very important, but it shifts part of this focus from treatment also to prevention and early diagnosis. And in this sense, the Europe's Beating Cancer Plan is important because it mentions also hepatitis. So it is stated there that the Commission will help ensure access to vaccination against hepatitis B and to treatments to prevent liver and gastric cancers associated with the hepatitis C. So the idea is that European Union will use this program and funding which are at its disposal to help member states provide treatments to prevent cancers which are associated with hepatitis C. And in this sense, this is a very big breakthrough because European Union really commits itself to providing the important funding for the types of treatments which may result in gastric cancers and which are caused by hepatitis C. So in this sense, the Europe's Beating Cancer Plan, even though it is focused on cancer, will also be used, and part of its funding will also be used to tackle conditions which are related to hepatitis C. And I think this is very important because this creates a chance to actually to commit big parts of European funding also for hepatitis C, which is one of the most problematic communicable diseases which are currently existing in the European Union. And the last point that I wanted to make about funding, I will not mention cohesion policy now, but it is also very important because it can provide funding for health infrastructure, especially for less developed countries like the European Union. But in addition to this, what will be, I think, very important when we discuss treatment of liver diseases and hepatitis is Horizon Program. So Horizon Program is the science, research and development program, which is financed from the EU, which funds both basic and applied research in many areas. And for the first, and this is also enacted for the period of 7 years, the same as all other parts of European Union budget. But it is important that this program for the next 7 years will, for the first time, have healthcare as one of its priority missions. Beating cancer, but not only beating cancer. I think that also other treatments and the prevention of other diseases will also find its way in the new horizon. So this means essentially that EU funding for research, for basic research and applied research as well, will be streamlined much more than before for treatments, for healthcare treatments, for research related to healthcare treatments and everything which is connected to healthcare. So this is also one area where European Union can also do a lot in terms of providing financial instruments which can be used also to battle hepatitis C and other conditions which are related to liver. So what is important there also to mention is when you speak of Horizon, Horizon is one policy instrument, unlike cohesion policy, where everyone can compete. So when you speak, for Horizon funding, Heidelberg, Sorbonne, Leuven, Zagreb, Split University, they all compete against each other, and the most advanced projects, the most advanced research proposal get funded. Which means, unfortunately, that most of this funding goes to the Western European member states. But I think that if Croatian universities pull themselves together and create joint research proposals, maybe also collaborate with universities and research institutions from other European Union countries, a lot of this funding can also go to Croatia as well. But we will have to make sure that to raise awareness of all of these funding possibilities which exist on the European level at the moment. So to sum up, European Union's role in beating cancer and in healthcare in general, but also related to hepatitis and other liver conditions, is secondary to member states. But European Union has a lot of instruments which are at its disposal to help national authorities to improve their provision of healthcare. Healthcare has traditionally been one on the margins of European Union interest, but this has changed due to this policy initiative for beating cancer plan and because of COVID-19. And at this stage, we have unprecedented amounts of money in the EU budget under different funding instruments, which can be used to improve prevention, early detection, and treatment of many diseases, and hepatitis is one of those diseases, and other conditions related to liver as well. So I think that European Union's role in treating these diseases will increase. That European Union will be much more involved than before on this financial level, but also in terms of adopting various legislation on EU level, which I have not been able to mention, but there is a lot of EU legislation that is being prepared, like the European Health Data Space, new rules on clinical trials, on cross-border healthcare, etc. So definitely, we will. I think that we in Croatia will have to keep track on what is going on European level, try to collaborate, and try to prepare projects for funding, which will, I believe, be very important to increase and improve treatment of various diseases in the Croatian healthcare system. So this was more or less what I wanted to say. Again, thank you for inviting me, and if there are any questions or comments, I will be happy to answer. Thank you very much.
Thank you very much, Mr. Sokol. And ladies and gentlemen, our next section brings us back to the topic with which Hepatos activities began, securing wider regional commitment to the viral hepatitis elimination. COVID-19 threat to public health, which certainly needs special attention, also pointed out the importance of not abandoning previous achievements in public health, the need to try to keep the current status and avoid taking step backs in attempt to not lose the achieved momentum in eliminating viral hepatitis as well as the other liver diseases, since their neglect can lead to further complications such as HCC. To talk about the feasibility of elimination by 2030, what needs to be done, I'm pleased to introduce Professor Adriana Vince, head of the Croatian National Reference Center for Diagnosis and Treatment of Viral Hepatitis of the Ministry of Health of Zagreb.
Okay, good afternoon.
Hello.
Hello. So it's a privilege to be with you today, and I especially want to thank Tatiana Reich for inviting me to speak on this very important topic today. Everything started back in 2016 when WHO has set a goal of elimination of viral hepatitis as a major public health threat by 2030. So this was written in WHO hepatitis global strategy, and it was based on the data actually for many countries that were collected during 2015, mostly by CDA, Center for Disease Analysis. So they had different sources for their data, and some of those sources were like published studies, surveys, or expert opinions. So they made some estimations and modeling for the prevalence of viral hepatitis B and C for many countries in the world, but nevertheless, those were mostly estimation based on the data that was available. So what was there to see for hepatitis C, which, as we have seen today, is a major driver of hepatocellular carcinoma? So they actually concluded that estimation is 71 million people around the globe were actively infected with hepatitis C in 2015. A significant number of those people will end with liver cirrhosis and, even worse, liver cancer. So a lot of deaths were also attributed to hepatitis C. In those years, it was more than 400,000 deaths attributed to hepatitis C. But what was important at that time in 2016, we had new antiviral drugs. So we had direct acting antivirals, all oral drugs that were available since 2015 that had effectiveness of elimination of the virus in an individual of more than 95%, almost 100% effectiveness. So this has really encouraged WHO to push the targets very ambitiously. So they have set the 3 basic targets regarding important indicators. So they wanted to see globally by 2030, 90% reduction in hepatitis incidence, 80% of treatment available persons with chronic hepatitis C and B to be treated. And this all should be leading to 65% reduction in hepatitis C mortality. Okay, so then afterwards, the regional plans for viral hepatitis have been made, also European regional plan, and European Center for Disease Control also worked along on development of this plan, but they also tried to collect their own data. And just recently, at the end of March 2021, the technical report for ECDC was published on the Sustainable Development Goals and hepatitis B and C in the EU and European Economic Area. So what does it really say on mortality? It says that more than 23,000 persons were reported to have died of hepatocellular carcinoma in 31 countries of EU and EEA in 2015, just when we started to talk about the elimination. And there were even more deaths from chronic liver diseases from the compensated cirrhosis, so more than 41,000. So this makes actually huge mortality. More than 65,000 people have died annually from complications of chronic liver disease. And so this really made ECDC to work harder on that problem. So Europe being European Union and European Economic Area being more developed countries, they even pushed the more ambitious goals to 2020. So they wanted till 2020 to see 50% of those with chronic HBV and HCV diagnosed and 75% of diagnosed who are eligible for treatment to begin their treatment. But what actually happened as ECDC got the information, the data back from the member countries, so they could, this was disappointing actually because most of the countries did not send the data ECDC wanted to collect. And of those who did send, you can see more than 50%, they did not reach the 50,000 goal of 50% being diagnosed. Only 6 countries, you can see, went over the 50% of patients with chronic hepatitis B or C being diagnosed. So, executive summary of this technical report says that available data indicate that most countries are not on the track to meet the WHO goals by 2030. There is suboptimal coverage of harm reduction measures for people who inject drugs. Missing reliable data presents a huge challenge to making progress on the viral hepatitis epidemic. So we need improved monitoring systems and reporting urgently if we want to take proper action on hepatitis B and C in the European region. And so here is a lot of words again, but this is already answering my question or what I was supposed to answer. According to ECDC, priority areas for action: improve monitoring, data collection, modeling, seroprevalence, cohort studies, death recording, scale up both prevention and testing services as part of harm reduction centers for people who inject drugs. Scale up general testing, reliable national estimates of mortality attributable to hepatitis B and hepatitis C. Because nowadays in most countries, we do not know whether a person when dying of cirrhosis or being ill with cirrhosis has HCV or HPV infection, or the monitoring system doesn't know. So we really don't know the impact of good things we are doing. ECDC wanted even to push the things on to make something better for proposal for European countries. So for 4 years, they have tried to develop a standardized European protocol for hepatitis C prevalence surveys in the general population. And it was just recently published in the Frontiers in Public Health, but also as a technical report on ECDC side, where countries can really decide about sero survey they want to choose for their own circumstances. Or another example I can give you to answer the question, what should be done if we want to make the elimination point feasible, maybe by 2030. So this is the study being performed by 8 Central European countries, and it was published just before the COVID set in February 2020. Named How Close Are We to Hepatitis C Virus Elimination in Central Europe? Those were mostly clinical experts answering the questionnaire, and they had to score for particular factors affecting HCV elimination from 0 to 4. As you can see on this table, the minimum score got actually the national screening program, then political will, and linkage to care program by 8 countries. So conclusion of this study was that access to therapy is similar and it's no problem anymore to direct acting antivirals, but there is general lack of political will to implement national screening programs and HCV elimination. They think it will not be possible in the region by 2030. So this was even before COVID. And COVID was a disaster and still is. And this is one of the worst diseases the mankind has seen. Those of us who have worked with those patients, we can really prove it. So what during the COVID and hepatitis? I can just tell you about the data I have, and this is for Croatia. Here you can see total reported patients with hepatitis C and total treated patients for hepatitis C in the last 5 years. So just look at 2019 before COVID and 2020 during COVID. So you can see total reported cases we had on average 200 here, and here is the drop of more than 60%. Also regarding treatment, we have seen drop, it's about 25%. It is not that bad because we had the year before already prepared patients for the treatment, so the drop was not that bad. We will see what will happen this year. So obviously this was not the natural course of the disease, but this was COVID. So if you ask me whether the elimination of viral hepatitis by 2030 is feasible, I honestly don't know. For some countries, it might be feasible. For some countries, it might not. Because right now, we really don't know where we stand, even more with this interruption of COVID. So right now, we really need updated sero surveys to see the seroprevalence in general population. And we really need good monitoring of mortality and morbidity data connected to chronic hepatitis B or C. So to conclude again and to answer the question from the beginning, what has to be done or what would be the biggest challenges to go back to the focus of viral hepatitis? But whether we will achieve the elimination, we don't know, but this is not the reason, this is not excuse not to go back to the problem, because you can see mortality is huge. So the best thing would be to implement the national hepatitis plans. Most of the countries, they have written the national hepatitis plans according to the WHO guidelines, but they are just not being implemented. As for Croatia, we have written the plan since 2019, but it has not been implemented. It is still sitting in the Ministry of Health, nothing being done about it. Because those national hepatitis plans, they have everything that has to be done included. Scaling up screening, care, treatment services, raising awareness, how to monitor the indicator, continuous education of primary care physicians and their teams, and most important, multidisciplinary approach to people who inject drugs. So if not implementation of national plan, then at least a national screening, some kind of national screening program should be set up, or some kind of new survey, sero-survey in general population, just to see where we are right now. And on the other hand, it is very important to stress that now is the time for patient association to take active part. Now is the time for patients to speak up, because medical society has been focused on COVID-19, post-COVID period, organization, reorganization. We have really been kind of exhausted by COVID-19 vaccination now, whether it works totally or not, etc., etc. So this problem will not go away, even if we don't have the fourth and the fifth wave. So patient association should take active part. They should go and speak out of their needs and the problem they see they have. And meeting like this, I think it's a perfect time to speak out of those forgotten needs, I would say. Okay, with this, I would like to thank you for your attention. Thank you.
Thanks to our Professor Vince. Now we move across the Atlantic, following our two speakers. Our next speaker created and directs the Coalition for Global Hepatitis Elimination of the Task Force for Global Health. The coalition is a community of practice providing technical assistance and monitoring progress toward hepatitis elimination in over 180 countries. Dr. John Ward will present today HCV and COVID-19 impact of overlapping pandemics. Good morning, America. Hi.
Good day. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in the United States. I was asked to give an update of the impact of the COVID-19 response on our efforts to eliminate hepatitis. We're in the midst of a pandemic of COVID-19 that was first recognized in the first months of 2020. It continues to spread around the world, responsible for over 172 million infections and over 3.7 million deaths. In the first months of the pandemic, there was a reliance on non-pharmacologic interventions for prevention, including social distancing to reduce the risk of person-to-person transmission, and an increased focus on hygiene and infection control. Those measures had an impact on the delivery of the interventions considered essential for reaching our targets for hepatitis elimination. And we'll be looking at the impact on vaccination, harm reduction, and hepatitis B and hepatitis C testing and linkage to care. There was indeed a large impact on the delivery of vaccination because of the changes in social distancing within clinical settings and the reluctance of patients and their families to visit clinical settings for vaccinations. As you can see here, estimated 85% of countries reported some decline in vaccination. I've given you some examples of the extent of those declines by countries that are in the literature. WHO estimates if these interruptions are prolonged, you could be looking at over 5.3 million new HBV infections occurring among infants and remaining chronic, and over 1 million future hepatitis B virus related deaths. It is interesting in looking at information from the United States and other countries, there does appear to be less of an impact on birth dose delivery, perhaps because women continue to deliver in hospitals where that birth dose can be provided. Declines have also been seen in the delivery of harm reduction. I'll give you an example from Spain, where there's was the decrease in the number of clients seeking those services, a reduction in the number of needles distributed, raising concerns of unsafe injections and increased HCV transmission, decrease in the delivery of both drug treatment as well as HCV treatment in these settings. So you see by the lines there in the purple, there was some improvement over time. Of interest, none of these sites were providing COVID-19 tests, a missed opportunity of using these testing programs for hepatitis to be part of the COVID-19 response. Our coalition, beginning in August through December, did a survey of clinicians and hepatitis program managers to assess the impact on hepatitis testing and treatment. We have 103 clinicians and program managers from 44 countries responded. 65% reported deferring 50% or more of in-person clinic visits over this period, with 80% reporting some disruption in hepatitis B and hepatitis C testing and treatment services. However, as indicated by the green lines in this graph, when you ask them to compare the most heavily impacted month with the most current month, there was some improvement in the delivery of those services, although not yet reaching that pre-COVID level. A similar trend was reported from 34 countries in Europe, where you look at looking at 2020 March through May versus March through May of 2019. There were profound disruptions as indicated by the blue color for hepatitis B and hepatitis C. However, by June to August, that level of disruption was much smaller, indicating some improvement. The US CDC just several weeks ago reported trends of HCV testing in the United States, reporting about a 60% decrease through January through July of 2020, particularly in those first few months of that year compared to the previous years as shown here, but a recovery to only about a 6% decline by July of that year. And then lastly, looking at the data just recently reported from WHO in that bottom graph from March of 2021, only a very small percentage of the clinics responding to this survey were reporting severe disruptions in services. So it does look like those services are improving over time. There has been some estimates that if these interruptions of testing and treatment are prolonged, you could have some profound missed opportunities, resulting in increases in infection, increases in hepatocellular carcinoma, and deaths that could have been prevented with interventions. So we'll have to see how these trends in testing and treatment for hepatitis C continue as the COVID-19 pandemic persists. That said, in addition to challenges, there are real opportunities coming from the COVID-19 response. And I've given you some examples here, and I'll go into some more detail. Some of the increases and improvements in testing and treatment is because of the various new strategies that clinicians and program managers are deploying. This just shows you the large increase in the use of telehealth that was being applied to continue to deliver care and treatment, including for hepatitis over this period. A group in England recognized that some previously homeless individuals were getting housed in response to COVID-19. They took that opportunity to deliver an hepatitis C testing and treatment program, finding almost 18% of those individuals had evidence of previous HCV infection, finding 133 currently infected individuals, offering treatment to 69%, and starting treatment on 90% of those individuals. In Northern Italy, they took the opportunity of integrating COVID-19 and hepatitis C testing together, finding that about 49% of individuals accepted that hepatitis C testing, finding 72 individuals who had evidence of previous HCV infection, including 46% that were unaware of their infection until they were tested through this integrated approach. And now other parts of the world are beginning to see how they can integrate COVID-19 and hepatitis testing. In our own survey, respondents reported improvements in laboratory testing, improvements in clinical training for the management of infectious diseases in their institutions. Both of those improvements can be applied toward hepatitis to improve hepatitis testing and linkage to care. And indeed, there's been a large investment globally in improving diagnostic capacity to detect virologic infections by organizations such as the Global Fund. Just one example here, where they've committed to procuring at least 27 million molecular tests for low and middle income countries. In Africa, CDC made it a large priority to improve diagnostic capabilities for virologic testing, going from essentially no laboratory capacity for this in national laboratories to every laboratory in Africa having virologic testing for COVID-19, but that can now be applied to hepatitis B and hepatitis C testing. And that can obviously be a key strategy to help us overcome a long-standing challenge for hepatitis elimination, which is the large proportion of persons still unaware of their hepatitis C infection, as shown here in this slide, as well as hepatitis B infection. So in summary, the response to COVID-19 resulted in immediate and dramatic declines in hepatitis prevention, including vaccination, harm reduction, testing, and treatment. It does appear that access to hepatitis-related services appear to be improving in many countries, although that probably is very much related to the trends in COVID-19 diagnosis. And so continued monitoring is needed to have an appropriate response to improve those programs, as well as to inform modeling to assess the full impact of those interruptions. There are responses to COVID-19 provide real opportunities to improve hepatitis testing and linkage to care. We need to see what adaptive strategies need to be continued that simplify testing and treatment. There are opportunities to integrate hepatitis and COVID-19 testing that can need continued exploration. We need to continue to see how we can utilize the expanded virologic testing put in place for COVID-19 to apply that to hepatitis testing, particularly as cases of COVID-19 wane. And then lastly, we really need to see how we can look to integrate hepatitis testing programs into pandemic response, beginning with COVID-19, so that they can really be considered essential health services and receive the funding that they need throughout the year. Hope this information has been helpful, and thank you again for the invitation to be part of this meeting.
Thank you, Dr. Ward. The Polaris Observatory collects and reports HCV, HBV, and HDV epidemiology. and disease burden and treatment rates for all countries. Homi Razavi is founder and managing director at the Center for Disease and Analysis Foundation, and so will tell us more on impact COVID-19 had on HCV elimination in Europe. Mr. Razavi, are you ready?
Hello.
Hello,
Before
good
the
morning.
COVID-19 pandemic.
Mr. Razavi, is everything all right? Can you hear us?
Hello, everyone. My name is Homi Razavi, and I am with CDA Foundation, an organization that has been working on viral hepatitis elimination since 2012. It is a pleasure to be here today, and I would like to thank the organizers for inviting me to participate in this important conference. As we all know, globally, COVID-19 pandemic has had a very large negative impact on all societies and countries. However, what is not clear is how much of an impact it has had on other health programs. Today, I would like to tell you about some of the Markov modeling work we did to estimate the impact of COVID-19 pandemic on HCV elimination efforts. As you know, in 2015, countries endorsed a global health sector strategy to eliminate viral hepatitis B and C by 2030. These elimination efforts were made possible by the new direct-acting antiviral treatments for hepatitis C that provided a cure in 8 to 12 weeks. In addition, we already had effective vaccines to prevent hepatitis B infections and antiviral treatments to prevent the progression of liver disease in HPV patients. The COVID-19 pandemic disrupted many of these programs, and the goal of the study was to measure that impact for HCV programs. Before the COVID-19 pandemic, we estimated that 8 countries were on track to achieve the World Health Organization's target for hepatitis C elimination by 2030. They're shown in the green in this slide. Another 14 countries were on track to achieve the same targets before 2050, and they're shown in yellow on this slide. If you look at the bottom of the slide, you'll see the name of these countries. Now, these were our estimates based on the 2019 diagnosis and treatment rate. At CDA Foundation, we update hepatitis C Markov models for 110 countries each year. This is made possible by our collaborators in each country who provide the data for its screening, diagnosis, and changes in the guidelines. As part of this project, we used the models that were updated at the end of 2019 and then incorporated 2 scenarios. 1, if the programs continued on the same trajectory, so no COVID pandemic. And 2, if the national hepatitis C elimination programs were delayed by 12 months due to the COVID-19 pandemic. We use a forecasted estimate for total HCV infections, new infections or incidents, new hepatocellular carcinoma cases, and liver-related deaths between 2020 and 2030. By subtracting the estimates from the 2 scenarios, we were able to estimate the impact of a delay due to COVID-19 global pandemic on the hepatitis C elimination efforts. The results are shown here. A 1-year delay in the national elimination programs because of the COVID-19 pandemic would result in 906,000 fewer diagnosed cases and 746,000 fewer treatments. In interviewing countries, we found that in reality, in high-income countries, HCV screening and treatment declined by 40%, while the same programs in low and middle income countries declined by 70% because of the COVID-19 pandemic. Due to the lockdown, the fear of going to healthcare services, and the uncertainty in income, fewer people were being screened and treated for their hepatitis C infections. This reduction in screening and treatment will have a long-term impact on the mortality and morbidity associated with hepatitis C. We estimate that because of the slowdown of HCV elimination programs, there will be 623,000 additional HCV infections in 2030. These are cases that would have been treated and cured if there was no COVID-19 pandemic. Because there were more people infected, we also forecasted that there would be 121,000 new infections between 2020 and 2030. Delays in treatment allows for progression of liver disease. Thus, we forecast that there are delays caused by COVID-19 pandemic will result in 72,000 additional deaths and approximately 45,000 new HCC cases. As shown on this slide, countries that were most impacted by COVID-19 pandemic were high or lower middle income countries, where hepatitis C elimination programs were most active. As an example, if a country was not screening anybody for HCV and was not treating anybody, then the impact of COVID-19 in that country would be none. Thus, it makes sense that countries that would have the most active programs would be impacted most by delays caused by the pandemic. High and lower middle income countries accounted for 71% of all mistreatments globally. Although injection drug use has been well documented as the leading cause of new infections in Western countries, in fact, globally, nosocomial infection continues to be the largest driver of new infections. These infections are mainly in middle-income countries where people can pay for medical and dental procedures. Therefore, 83% of incremental incident cases are expected to be in middle-income countries. Hepatocellular carcinoma and liver-related deaths are highly correlated with treatment, where increased treatment has been shown to reduce new HCC cases and mortality. Therefore, the incremental excess HCC and liver-related deaths are expected to be mainly in high and lower middle-income countries where there were more active hepatitis C elimination programs prior to the COVID-19 pandemic. As you can see in this table, the Euro WHO region was disproportionately impacted by the COVID-19 delays with regards to liver-related deaths and new HCV infections. In this region, an excess of 13,800 liver-related deaths and 8,700 HCC cases were expected, with an additional 15,800 incident HCV cases between 2020 and 2030. This graph shows the historical number of patients treated for hepatitis C in the Euro region. Now, as you can see here, between 2017 and 2019, the overall number of hepatitis C treated patients was fairly constant, in fact. And what we assumed for the modeling purposes was a 12-month delay in all hepatitis C elimination programs. And this appears to be very, very aggressive. But remember, we did this analysis in April of 2020, and we had no idea how long the COVID-19 shutdowns would last and its full impact. In fact, in the original model, we assumed that the programs would pause for a full year and they come back to the original trajectory thereafter. As I mentioned before, by the end of 2020, we saw a 40% reduction in HCV screening and treatment in high-income countries and a 70% decline in low and middle-income countries. In 2020, the impact of these declines in the WHO Euro region was a 50% overall decline relative to 2019. This was based on countries' feedback and our analysis from medicine sales in each country. In 2021, we're really not seeing an increase in treatment. Therefore, our current forecast is that on average, we will see a continuation of treatment rates from 2020. With the new treatment data coming in, we feel comfortable that a full 12-month delay assumption may not be a bad assumption for 2020 and 2021 combined. Of course, the impact can be modified using different assumptions, And as shown here, a 5-month delay would result in 50,600 additional deaths as compared to 72,000 for a full year delay. The impact of COVID-19 pandemic on hepatitis C elimination programs in 2020 and 2021 was very disappointing, as many countries were just starting their programs. However, if we take a long-term view, we still have 8 years before 2030, and this is plenty of time for all countries to still meet the WHO targets. From our perspective, the most important question is what will happen in 2020 and thereafter. What is shown in this graph is our best estimate. But if treatment in European region goes down, then we're in trouble. If it stays at 2020 and 2021 levels, then we're not going to meet the targets in many countries except those who already had very large programs. However, if treatment can go back to the original trajectory, even increase, then in fact, we still can eliminate hepatitis C before 2030. If there's one message that I want to leave you with, is that there's still hope and we're not beyond recovery. In fact, we've already seen examples in low and middle income countries that large-scale screening and treatment programs are feasible. As shown on this slide, there are a number of countries around the world who can be used as best practices. Brazil screened 9 million people for hepatitis C in 2017 alone and treated 18% of the chronic cases. Rwanda has screened 4 million people, that's 60% of their adult population for hepatitis C, and treated 16% of all chronic cases. Egypt. They screened 48 million adults in 2018 and 2019, and they have treated 3.5 million people for their hepatitis C infection. Uzbekistan screened 62,000 people for hepatitis C and hepatitis B, with 32,000 of that population was actually done during the COVID-19 pandemic, along with COVID screening. Mongolia, as of 2020, screened about half of the total adult population and treated 22% of all their chronic cases. And Georgia, as of 2020, has screened 70% of the total adults and treated close to half of the chronic cases. In addition, if anything that COVID-19 pandemic has shown us is that large-scale testing and large-scale public health programs are possible in all countries. Therefore, I encourage all of you to use these learnings, apply them to your hepatitis C elimination programs, and put your country back on track to eliminate HCV by 2030. In conclusion, the COVID-19 pandemic is expected to result in excess HCV-related deaths and HCC cases, but there's still time to recoup these losses. Prior to 2020, a number of countries in Europe were making progress toward HCV elimination, while many others struggled to find patients to treat without a wide-scale screening strategy. In all countries, we need a comprehensive program that involves screening and treatment of HCV patients. Preliminary data suggests that treatment dropped by 50% in the European region in 2020. We expect the same in 2021, but the way in which programs do or do not rebound after this time period will be most important. COVID-19 is not going to be the last pandemic. If we're interested in HCV elimination, we can either work quickly to achieve that before the next crisis, or we can develop resilient programs to eliminate HCV before 2030. It is up to us to develop these programs, implement them, and follow them, and to make sure that our patients have access to treatment and all adult population is screened for HCV infection. Thank you very much for your attention.
Thank you very much, Mr. Razavi. And after America, we'll come back to Europe, ladies and gentlemen. And from European Center for Diseases Prevention and Control, we are joined by Ottilia Mart with presentation titled Estimate Proportion of Cirrhosis and HCC attributable to hepatitis B and C, an approach to monitor progress to reaching elimination target in Europe. Welcome, Dr. Mart.
Control. It is a great honor to contribute to this conference. My presentation today, it is about the ECDC approach to estimate mortality attributable to hepatitis B and C. It is very well known that WHO Global Health Strategy on viral hepatitis has set targets for a reduction of mortality by 10% in 2020 and by 65% in 2030. The year 2015 was taken as a baseline. WHO has also proposed a mortality indicator. According to WHO, mortality attributable to viral hepatitis B and C should be a sum of the number of deaths from hepatocellular carcinoma and number of deaths from chronic liver diseases adjusted by the proportion of people who died with chronic hepatitis B and C infections. This is based on the assumption that the relative risk of dying when chronically infected with hepatitis B and C from end-stage liver diseases, it is very high. So then the proportion of these infections among people with end-stage liver diseases is a good approximation of the attributable fraction. So then what we need are mortality data and prevalence estimates. In order to calculate the EU EEA mortality baseline, we requested the number of deaths by ICD-10 codes from Eurostat, and we looked for attributable fraction estimates by EU member state for 2015. The only available source for etiology estimates for each member state for this year were from publications of the Global Burden of Disease. However, we had to modify the definition of end-stage liver diseases to fit these attributable fraction estimates. So we changed from the hepatocellular carcinoma C220 to liver cancer, and for chronic liver diseases in the definition of WHO, we had to change to a larger understanding of cirrhosis and chronic liver diseases that includes direct deaths from hepatitis B and C, alcoholic liver disease, different types of cirrhosis and fibrosis, and several other ICD-10 codes. If we try to show this like in a visual representation, we apply a filter to raw mortality from liver cancer and chronic liver diseases. This is a very detailed view, but I'm showing it to illustrate that we applied attributable fraction estimates for each country to the number of deaths received from Eurostat. This slide also shows that we have and we propose baseline estimates for each of the member states. We will come back to Croatia. I'm coming to the results. Considering the number of deaths from liver cancer and chronic liver diseases in 2015, and after adjusting by the attributable fraction estimates, we arrived to a number of almost 64,000 deaths that were attributable to hepatitis B and C in 2015. In other words, in 2015, there were 64,000 people in EU, EEA that died of sequelae of hepatitis B and C. Because we have the baseline number, we can now provide the figures for how the annual mortality should look in 2020 and 2030. So acknowledging a reduction of 10%, there should be 57,000 deaths in 2020, and there should be only 22,000 deaths in 2030, which is in 9 years already. Since we are in 2021, the legitimate question is, are we on the right track? What we did to answer this question was to look into the period 2011-2018. 2018 is the year with most recent mortality data available. We did linear regression, and as we can see here, there is a small reduction in the number of chronic liver diseases death, but there is absolutely no indication of a decrease in the number of liver cancer death. However, we have to take this with caution because so far we cannot yet answer this question properly because mortality data are incomplete or provisional for some of these countries because there is an important reporting latency. We expect to have the figures for 2020 in 2023 maybe, and because ideally to have a robust estimate of the trend, we will need to have etiology fraction estimates for this number for each year, or at least for the milestone years like 2015 and 2020. Let's spend some time with mortality data from Croatia. Applying the same algorithm as for the EU, the number of deaths in 2015, which is the baseline, was 587 people who died from sequelae of hepatitis B and C, and this is represented of 41% of the 1,000 chronic liver diseases death and 36% of almost 500 liver cancer deaths. And because there are many clinicians in the audience, I have this breakdown of mortality denominator for chronic liver diseases and liver cancer here. As we can see, for chronic liver diseases, of the 1,000 deaths, a significant proportion were actually deaths from alcoholic liver disease, indicating that actually the 41% attributable fraction estimate for hepatitis B and C may be close to reality. Similarly, when we break down the liver cancer death by 4 digits ICD-10 codes, we can see that C220 may be very well estimated by the attributable fraction of 36%. Again, the figures for the annual mortality attributable to hepatitis B and C, Croatia should move from 587 deaths in 2015 to 200 deaths in 2030. Looking at the trends in mortality from liver cancer and chronic liver diseases for the same time interval, we can see that there is indeed a small reduction in the number of annual deaths from chronic liver diseases, and there is no indication of a decrease in the number of liver cancer in Croatia. In summary, Calculation of mortality following the WHO indicator was challenged by the lack of attributable fraction estimates to match the definition of hepatocellular carcinoma and chronic liver diseases proposed by WHO. We changed a little bit, and we adapted the denominator to the existent etiology fraction estimates. We arrived to a number of 64,000 people who died in 2015 due to sequelae of hepatitis B and C on the liver. There is a publication that I would recommend. It was just recently published by HCC EASL and a group of hepatologists from Bulgaria, Norway, and Portugal. The main idea is that calculating or estimating the etiology fractions in a standardized approach for EU, it is possible. ECDC is planning to refine the protocol and share it for use for the member states. We try to look into the trends. However, there are no indications that there is any reduction. We still have to be cautious that we still need to have better data, but it is obviously that efforts to identify people with chronic hepatitis B and C should be intensified, and people diagnosed with infection should be linked to care and linked to treatment. I want to thank you for attention, and I will be very happy to answer any questions. Thank you.
Thank you very much, Dr. Mart. Our next presentations, ladies and gentlemen, is titled Focus on the Global Hepatitis C Elimination Goal and EASL Recommendations for Complex Management of HCV in People Who Inject Drugs. To present, we are joined from neighboring Slovenia by Hepato's longtime friend and supporter Mojca Maticic from University Medical Center Ljubljana, Slovenia, and member of EASL Policy Public Health Committee. Mojca. Hi, Mojca. Welcome.
5 years ago, the advent of highly effective and safe treatment for hepatitis C encouraged WHO to launch the first global health sector strategy towards elimination of viral hepatitis as a public health threat, with quite 5 years ago, the advent of highly effective and safe treatment for hepatitis C encouraged WHO to launch the first global health sector strategy towards elimination of viral hepatitis as a public health threat, with quite ambitious goals to be fulfilled by the year 2030.
Mojca recorded her presentation, so we'll start from the beginning again.
Professor Maticic, do you hear us?
Yes, I do.
Okay. Yes, we do have some small technical difficulties.
Okay.
Oh, just a second. They say everything is okay. Sorry for this.
I can do it live if you want to.
Yes, actually, that's why I called you. Just a second, please, until technicians decide.
Hi, Professor Maticic, can you also share your screen as well, or should we do it from here?
I think I can share my screen as well. So you want me to do it live?
If possible, that would be great. Thank you.
Okay.
Thank you so much, and sorry for this.
No problem. I think it's here. Would you allow me to share it?
Yes.
Yeah.
Okay. Okay, do you see it?
Yes.
Okay, so hello to everybody. It's really an honor and privilege to be here with you today, and I'd like particularly to thank Tatiana for inviting me to give this presentation with the focus on global hepatitis elimination goal, but in the context of EASL recommendations for the complex management of HCV in people who inject drugs. So 5 years ago, as we've already heard, the advent of highly effective and safe treatment for hepatitis C encouraged WHO to set up these really ambitious goals that we've heard today. So to reduce the new infections of HCV by 90% and deaths due to hepatitis C by 65%, and all that by the year 2030. After 5 years, just recently, the Global Progress Report of WHO has been released, and it clearly showed that globally there are still 1.5 million new infections that happen every year and nearly 300,000 deaths that happen every year due to HCV infections. These are the data for 2019. But the Global Progress Report has also showed that viral hepatitis was one of the first areas to reach the Health Sustainable Development Goal targets for 2020, because, as you can see, there was a major increase in hepatitis treatment, which has already shown that it affected the mortality rate. However, on the other side, there is really an urgent need to rapidly accelerate hepatitis C diagnosis. And well, these are the data that are very clear. 62% of HCV infected have already received treatment in this period. However, only 21% of HCV infected have so far been diagnosed. Many gaps remain. However, it has been shown that the strategic direction for viral hepatitis with the least progress was actually delivering for equity, because the most marginalized, vulnerable, and underserved populations who face the highest rates of infection often have the poorest access to services. So it's quite obvious why to focus on people who inject drugs to eliminate hepatitis C, because there are estimated nearly 16 million of people who inject drugs globally, and and more than half of them are HCV seropositive. And the latest Global Progress Report of WHO has clearly shown that injecting drug use is still a major contributor to the number of people newly infected with hepatitis C globally. Well, in Europe, the problem is that among 2 million of HCV infected drug users, 3/4 come from the countries of Eastern Europe. Moreover, deaths from liver disease, including HCV, is as equally common as death from overdose in those aged over 50. And in the last decade, mortality due to untreated HCV infection has been increasing, particularly due to late presentation by people who inject drugs. We know that the road to HCV elimination is actually turned out to be actually very complex, and so a comprehensive strategy that addresses all steps of the healthcare of the continuum of services is needed, starting with awareness and prevention, testing and diagnosis, linkage to care and access to qualified health services, access to medication, and monitoring and evaluation. However, in the reality, and we are all very familiar with this figure, regarding elimination of hepatitis in people who inject drugs, the continuum of services looks rather like a very disappointing decreased cascade of care, with a very, very low proportion of those drug users who get treatment and those who are cured. But the magic bullet actually has been found by several modeling studies as well as real-life studies, showing that to improve this situation, the care for HCV needs to be patient-centered, which means that we need to bring the HCV care to the patients and not the vice versa. And there are 4 major pillars to achieve that solution, which are simplification, decentralization, task sharing, and integration. Now let's proceed to barriers and gaps to elimination of viral hepatitis in drug users, because every country has been facing them. And so European Association for the Study of the Liver, which is actually a home of hepatology, set up within its strategic directions also the framework for elimination of viral hepatitis as a public health threat, which works in 2 directions. First, on the public health, on the patient level, with producing particularly clinical practice guidelines and having a patient forum, and on the other hand, on the public health level, by launching position and policy statements. So let's first have a look at the latest, the final EASL clinical practice guidelines. This is a series of guidelines that started in 2014. And the final guidelines are very particular regarding the recommendations for the management of Hep C in people who inject drugs, which by definition include former injectors who've ceased injecting, as well as recent and current injectors who are on opiate substitution treatment. So all of them should be routinely HCV tested. They should have access to opiate substitution treatment and harm reduction programs. All of them should be treated according to the general recommendations. And very importantly, urgent treatment should be considered in this population to prevent further transmission of the infection. According to the final clinical practice guidelines in Europe, there are 4 combination treatments for hepatitis C with direct-acting antivirals, and luckily enough, 2 of them are pan-genotype. Why luckily enough? Because this enables really the simplification of HCV care, particularly for people who inject drugs, who may benefit the most from this simplification. What does it mean? Well, in pre-treatment assessment, we may actually omit genotyping or subgenotyping if this determination is not available, affordable, or if it limits access to treatment, which is very important. Then we still need to initially assess stage of liver disease, however, by using non-invasive, very simple and cheap methods. Luckily enough, pan-genotypic treatment regimens do not require specific methadone or buprenorphine dose adjustment. When it comes to treatment, it's very simple, patient-friendly, safe. It lasts only for 8 to 12 weeks. And as a test of cure, it can be omitted in all the adherent patients. This is the EASL recommendations, but it cannot be omitted in those with high-risk behaviors and those at risk of reinfection. Reinfection, as several studies have shown, is not that common, and so EASL strongly recommends that retreatment should be made if reinfection is identified after successful primary treatment of hepatitis C. Proceeding from individual to public health level, several studies modeling in real life have shown that broad accessibility to direct-acting antivirals can reduce HCV prevalence among people who inject drugs. And moreover, the combination of OST and high coverage of needle and syringe exchange programs can reduce HCV incidence by even more than 70%. But the last global progress report of WHO has shown that only 40% of countries have already introduced needle and syringe programs, and only 64% of countries have already introduced opiate substitution treatment programs. And very sadly, the high provision of HCV testing and treatment has been realized only in 1% of people who inject drugs globally. because access to testing and treatment is still limited for this population, even in countries with high provision of both services, due to several reasons, as you see here, starting with stigma, discrimination, misconception about adherence to treatment, and particularly due to restrictive guidelines. Because the recent study has shown that in Europe, there still exist countries that do not include drug users into their clinical practice guidelines. They do not allow treatment for active drug users or even for those on opiate substitution treatment. So EASL strongly supports the WHO elimination strategy, and actually in 2019, even EASL launched the position statement on elimination of hepatitis C with the key message that all European countries develop a comprehensive hepatitis C national strategy or action plan with the goals to increase awareness, combat stigma and discrimination, to implement harm reduction strategies, make DAAs available, improve access to treatment and care, particularly for those at high risk, and of course provide rapid testing. But EASL went a step forward, and in August last year, it launched a policy statement on drug use and the global hepatitis C elimination goal. Why? Well, it's quite clear that drug policy is a direct barrier to achieving the goal of HCV eliminations, and most of European countries do have laws that criminalize the possession and distribution of drugs. And so EASL thinks that it's time for change. It strongly recommends that all barriers to uptake of healthcare services by drug users be removed by changing policies and discrimination that hinder access. And this includes also the decriminalization of minor nonviolent drug offenses and the adoption of an approach based on public health promotion, respect for human rights, and evidence. What does that mean in practice? It means that to eliminate HCV in drug users, combining activities is required. It's not enough just to decriminalize the personal drug consumption and possession, but it needs to be integrated with interventions such as HCV testing, treatment, and counseling. But of course, we live in the COVID era, and it has been shown already today that COVID has dramatically intruded into the management of Hep C in people who inject drugs. It particularly affected the testing of HCV, as we see here, and particularly within the community, which of course affects mostly people who inject drugs. So EASL, together with European Society for Clinical Microbiology and Infectious Diseases, already in April last year, released the position statement on the care of patients with liver disease during COVID-19 pandemic. It has been updated in August last year, and actually it strongly supports to continue the activities towards elimination of viral hepatitis if possible. And of course, it also released the policies, the position statement on the COVID-19 vaccination in patients with chronic liver disease, which was released in February this year. So to conclude, ladies and gentlemen, a take-home message should be that actually the cornerstone to get back on track to eliminate HCV drug users, which has been told so many times today that is utmost important, is that we go on patient-centered services and that we urgently focus on inequalities. And last but not least, let me invite you to the International Liver Conference, which is going to be completely virtually at the end of June, and where all these issues are going to be discussed in detail. Thank you very much.
Thank you, Dr. Maticic, Hepatos, a long-time friend. And ladies and gentlemen, it's time for the last presentation today. The patient involvement is an important part of any change and progress. So we are happy today to welcome Rachel Halbert from World Hepatitis Alliance, who will present COVID-19 impact on HCV testing and Hep Can't Wait campaign. Rachel?
Good afternoon, everybody. First of all, I'd just like to say thank you very much to Tatiana and her colleagues for arranging and organising this event and inviting us to speak. So my name is Rachel Halford and I am the European Regional Board Member for the World Hepatitis Alliance. And today I'm here just to provide a little presentation around the impact of COVID-19 on hepatitis elimination in Europe from the patient members' perspective. And within that, on the end, I'm just going to provide a little overview of our World Hepatitis Day campaign this year. So first of all, just a little bit about the World Hepatitis Alliance. We're a global patient-led and patient-driven non-for-profit organisation. So we have over 300 members in 100 countries. Our mission is to harness the power of people living with viral hepatitis to achieve its elimination. And how we do this, we work with governments, national members, and other key partners to raise awareness, influence policy change, and drive action to find the millions of people unaware of their condition in hepatitis. So part of what I'm going to feed back today is that we completed a survey in last March, on just trying to find out the impact of COVID on our patient organisation. So this was a community survey. Within this, we had 132 responses from organisations across the world, and this is providing us with a global snapshot of how the pandemic was affecting services. Obviously, the situation has changed somewhat since then, and we are currently undertaking a new survey. So top line feedback was that 94% of people who completed the survey reported that services had been disrupted by COVID. And this is no big surprise for any of us. I mean, this is an unprecedented time and there's been a massive impact for all of us. 36% of respondents reported people were able to access hepatitis C testing. This was quite surprising, I think, because actually, you know, I know in the UK, for example, that testing was severely affected. Quite shockingly, though, one of the other top line reports was that a quarter of the respondents reported people were unable to access hepatitis C treatment. And this truly does have an impact on the elimination agenda. So just kind of delving down a little bit deeper within these results, I'm just going to provide you with a little top line of this is what is Europe. When we're talking about Europe here, we take just a picture of what countries we're covering, etc. So across Europe, we've got 68 members in 35 countries. And it's really quite a large region, as you can see by the map that we have here. So just to give you a few of the little the questions that were asked and some of the feedback. So one of the first questions we asked were, are people living with viral hepatitis who are on treatment able to access their medication at this time? This was really difficult because for many countries, this means going out, putting yourselves in vulnerable situations. However, 80% reported back that they were able to access. Of that, though, we've got this 20%, and we kind of looked into it a little bit deeper just to find out what were the reasons that they couldn't select, because it's really important, that 20%. 50% of those who responded, health facilities were shut down. You know, and I think this is important to note, is that our daily kind of access into healthcare changed significantly. Of them, 83% had travel restrictions. You know, and I think that we must have seen that across all of our countries, that impact on a movement, health facilities, etc. The next question we asked was, are people able to access testing for viral hepatitis? You kind of unsurprisingly here, but this is, as I said earlier, the really worrying when we're talking about eliminating. So it's not just about testing, but it's also about people accessing their treatment. But in terms of testing, it's really important. So 41% could still access treatment, but 41% also could not access treatment. So we really, really important to delve deeper into this. And actually, so these are the reasons. The largest percentage, and I think that, this isn't surprising, 71% of people have avoided going to testing facilities. We cannot underestimate the impact that COVID has had on people's mental health, and in terms of particularly if they feel vulnerable and within their health, you know, the thought of going out and putting themselves at risk of a COVID, you know, an unknown disease, of course, they're not going to want to travel. 35% were unable to travel. There was 21% where medical staff were no longer testing for viral hepatitis. You know, I think many of us have seen this, that, you know, health staff that have been working on hepatitis have been deployed into working in COVID. Of course, we know that. And it's been necessary to do that. And 20% testing, 28% testing facilities were closed. I have to say, as I said earlier, I find this one quite surprising because, you know, it's not been my experience of the UK, but, you know, it's been like 100% almost of testing facilities closed. However, it's great to see that some countries were still able to test. And then just swiftly moving on then, we just delved again a bit deep. Oh, sorry, next one is the adequate information about COVID. So this was really interesting for us. You know, it's, you know, was there information that was accessible for you in your country in terms of about COVID? And for you, if you were living with hepatitis, what did COVID mean for you? And this was really confusing in the beginning. There was a real lack of information around the impact of COVID on people with liver diseases. I know that there was some time later, more information came out, but it was there was not a lot of clarity. So has adequate information about COVID been provided to you in your country for people who are living with hepatitis? And actually what was, you know, disappointing or unsurprising was that, you know, 41% of people were unsure. And actually what that says is that no, there wasn't. So whilst we had 29% of people saying no, that they didn't believe that the information was there, 41% saying they're unsure, actually, that probably means that they're in the no bracket. So there was only 29% of adequate information on COVID. What we did as a patient organisation, so I run a patient organisation in the UK, the Hepatitis C Trust, and what we did in the end was that we actually created our own COVID information. And I think that, you know, my experience, you know, talking to colleagues across Europe is that a lot of patient organisations did this themselves as well, to make sure that the information was clear, that the patients that they were working with fully understood it and knew how to protect themselves and when to be concerned and when not to be concerned. I think it was really important. So just kind of delving in a bit further, we kind of went then and asked, you know, have services provided by your organisation been affected by the COVID-19 outbreak? You know, and here's a little bit of feedback, you know, and I think it's really important to gather comments from people. And as you can see here, you know, our harm reduction sites mostly work on distance mode. HCV testing is available, but people are not coming into testing because fear of travel, something I mentioned just more.
Sorry, I didn't quite catch that. Could you...
Sorry, that was my phone jumping in, asking to see if he could join in and pick up the questions. Okay, so swiftly moving on, projects such as prison settings have been postponed. We saw that, I think, in most countries, that prisons went into absolute shutdown. They had to keep people in prison safe, but also there was a lack of resource because so many officers and staff were affected by COVID. Most future projects are postponed. Street work for homeless and people who inject drugs are experiencing significant burden. I don't think this is unique to one country. I think this has been the same across the world. So no longer providing face-to-face, we found the same. You know, face-to-face has been really difficult. It has been, if people are providing face-to-face, it's been about having all the PPE, you know, personal protected equipment. It's been a very different environment we're working in. So within this comment here, such as education, peer education, information and support appointments, viral hepatitis screening clinics, and hepatitis B vaccination clinics. Treatment delayed. Obviously, you know, for a lot of people, treatment's been delayed, unable to get people treated for hepatitis at present, no new treatment starts, staff redeployment, and we've heard this everywhere, staff redeployment. Next, you know, on the last question I'm going to talk about here really is how is your organisation minimising the impact of COVID on people living with viral hepatitis in your country? And just this, you know, these two comments here, you know, outreach workers continue to deliver medication to the homes, doorways, hostels and tents of those vulnerable individuals who've already started their treatment pathway, and the HCC van is delivering a needle exchange service. We continue as a team to raise awareness, map our areas and engage in Zoom conferencing to maintain relationship with partner agencies, maintain our well-being and skills, our readiness to re-engage as soon as possible. And I think really what this comment says is that, you know, as patient organisations, as civil society organisation, that, you know, we just adapted. I think that we had to, and the majority of people I speak to have just adapted. And I think that that's one of the real gifts that civil society organisations bring. Another comment here was we've been supplying food parcels and topping up phones for the most isolated or high risk groups, and providing telephone support and guidance. I think so. Really, just to summarise these top line comments. Oops, and I've lost the slide there. So I'm just really just going to bring it back and just say that, you know, I think that the survey has been really important. It will be really interesting to pick up and get the feedback when with the new survey that we're completing, and we really look forward to providing you the results and hopefully seeing how people have adapted and where we're at now as we are learning to live within this new restricted environment. So just going to give you a little update on the Alliance now and our January 2021 update. So nearly all participants agree that the COVID-19 pandemic negatively affected hepatitis C services. However, they also reported that most people living with hepatitis were able to access treatment, which is really, you know, that's quite something. And a year on from this first survey, it shows that we've learned to adapt. More than half respondents reported viral hepatitis C testing, treatment, vaccination, and adjacent services have been affected, and adjacent services have been affected by COVID. Respondents reported that the biggest reason people were not accessing testing at this time was the public avoiding healthcare settings, you know, and it's going to take a little while for this to change. I think, as I said earlier, we cannot underestimate the impact that COVID's had and on people's mental health in particular, you know, and them being able to feel safe to go out and to interact, and life will perhaps never quite be the same again. So the COVID, just in summary then, the COVID crisis has impacted the ability of most civil society organisations to deliver hepatitis services. That most civil society organisations have evolved. We've evolved our practices and our services to meet the needs of the communities. There has been a reluctance of people to access hepatitis C services because of their fear of COVID. But that barrier can be addressed through decentralisation of these services. And then civil society organisations, there's a continuing need to support to operate and tackle the dual threats of COVID and viral hepatitis. So, you know, that kind of impact on mental health and then the accessing into the services. I do hope that that's not too garbled on the end there, but I think it's really interesting to get this sense of how it's been for patient organisations on the ground, rather than somebody who sat in an office and kind of giving you a broader Europe. It's nice to hear the voices of the people on the ground. So just to finish up, because I'm really pushing on my time limit here, I just really want to give you a little overview here now of our World Hepatitis Campaign at the Alliance. So this is the new campaign, Hepatitis Can't Wait. So World Hepatitis Day is on the 28th of July. We all know that, I think, by now. And this year is the 10th anniversary of the official World Hepatitis Day. And the Alliance's new campaign is Hepatitis Can't Wait. So held on the 28th, it's a day to raise awareness of viral hepatitis, one of the world's officially mandated global public health days. So on this day, we aim to unite global community to demand action from decision makers to prioritise the elimination of viral hepatitis, as we all know, one of the most deadly and neglected diseases. So this new hepatitis campaign is the new campaign theme to launch in 2021. And we highlight the need to really accelerate hepatitis elimination efforts, especially with the impact of COVID and during the COVID pandemic. So this will bring the World Hepatitis Alliance and our global network of members, countries together to lead this campaign internationally. Sorry, that's a bit garbled, but really this is what I'm trying to say is this is about bringing us all together. It's about raising awareness that actually we can't wait. We only have, you know, the global elimination goal is 2030. We are now in 2021. We are in our, 9 years to go, and we can't wait. So we really, this clock, the ticking of the clock, the countdown, it's really important. I think visually it works really well just to highlight. So here's some of the top line information, really, just to kind of bring it home. Newborn babies can't wait, really important for the vaccinations. Policy makers can't wait to act, they need to act now. There's 2.3 million people living with HIV and hepatitis C. It's an enormous amount of people who inject drugs. So I think it's really important to say that part of this campaign also is about really targeting the marginalized communities, those that, whether it's, people who inject drugs, refugees, newborn babies, vulnerable populations, indigenous populations, people who have TB and hepatitis, people who have HIV and hepatitis, whether that's hepatitis C or hepatitis B. Men who have sex with men. So there is no, I guess the top line is there is no group of human beings that can wait for us to for them to be treated, for them to be diagnosed. So this year our campaign is really about Hep C cannot wait. So finally, just to give you a little overview of some of the materials, you can access the materials from the World Hepatitis Alliance website. They are printed in lots of different languages. You can adapt the posters, you can include your own pictures. And if you have any problems at all, please don't hesitate to contact our team. I do hope that you've been able to take something away from this. I'm sorry if there's a little bit garbled in between, but really, really grateful to be able to have this opportunity to share some of the patient organisations, civil society organisation views. And I wish you a very good rest of the sessions. Thank you very much.
Thank you very much, Rachel Halford. Ladies and gentlemen, we come to an end. So before we say goodbye, it's time to say goodbye, but without crying. Before that, it's time for your questions, Q&A, and time for some conclusions. This part will moderate Ivana Mikolašević, an assistant professor of internal medicine at University Hospital Rijeka and University School of Medicine Rijeka, and hospital in Zagreb, Merkur. Okay, welcome, Ivana. Tatiana is also ready, steady.
Okay. So, dear professors, dear colleagues, just a second. So I would like to thank you for supporting this conference, and thank you all for supporting Croatian Liver Week. And in front of the organization board, I would like to thank to all speakers for these excellent presentations. And as Daniela said, is there any questions regarding this session?
So if I may jump in, Tatiana is here. Just it was announced that people can put their questions into the chat or Q&A session. I don't see it on my screen, so probably some of you also couldn't see it. So please feel free just to unmute your microphone, and then you can ask questions, because some of our presenters has rejoined us, like Shira, whom I see right now. So yes, if you do have any questions, please feel free to ask now. maybe I can ask Ivana, as she's here as a gastroenterologist, I mean hepatologist, in regards with alpha fetoprotein, because it was mentioned several times today, how reliable it is as a predictor of hepatocellular carcinoma. I mean, how much elevated it should be to, you know, for a patient to be concerned. Why I'm asking that? Because it is a little bit elevated in my own case, and that's why. And as I am patient myself, former patient, yet I know that I'm still in risk. So this is my question.
Thank you, Tatiana. We have to keep in mind that around 30% of all HCC cases have normal values of alpha fetoprotein. We are now investigating other biomarkers for HCC detection.
Yeah, we heard that.
Yes, thank you. Is there any other questions regarding this session? If no, my question is, why is non-alcoholic fatty liver disease important to us? So we know today that NAFLD is the most common chronic liver disease. And according to recent publication, around 25% of population have non-alcoholic fatty liver disease. Also today we know that NAFLD is not only a liver disease, but actually it is a multi-system disease that is mainly connected to chronic kidney disease, cardiovascular diseases, and type 2 diabetes. Also today we know that NAFLD is a growing cause of HCC, and we know that up to 50% of all HCC cases can be developed in NAFLD patients who do not have liver cirrhosis. NASH cirrhosis and HCC due to NASH are increasing as an indication for liver transplantation. And accordingly, with the aim of raising NAFLD awareness as a silent epidemic of 21st century, we will organize 2 public health actions. So the first one will be tomorrow in city Zagreb, and the second one will be on Friday in city Rijeka. On Saturday, we will have non-alcoholic fatty liver disease symposium in Opatija. So we will be happy to welcome you all in Zagreb, in Rijeka, and in Opatija. Thank you very much. Tatiana.
Tatiana, well, yes, yes, it's great. Thank you, Ivana, so much for this announcement. And as you all know, tomorrow is NASH Day for the, I think, 4th time in a row, or even 5th time. I'm really not sure. Anyway, it is globally. It is now globally recognized, and since this year, it is going to be the 2nd Thursday in June. I am happy to say that this NASH Day is this year also endorsed by EASL, European Association for the Study of the Liver, which means that also expert community has recognized patients' efforts to raise awareness and join. So only jointly we can really do some changes. And as we heard today, when we talked about obesity and all these liver diseases, it is really crucially to be aware of all threats that this non-alcoholic fatty liver disease is now giving to us. So that would be also all from my side. I really thank you all. And really, I'm happy that Hepatos from this year, together with the Croatian Gastroenterological Society, is organizing the whole week, which we call Croatian Liver Week, and which will be held from now on every second week in June in around the NASH Day. So yes, that's all from us, from me, from Zagreb. So maybe Daniela is our moderator.
That's all folks. We can say that's all folks. See you next year live in Zagreb, of course.
Of course.
We'll stick together. Yeah, and stay together now. Thank you for your attention. Stay negative and think positively. Bye.
Bye.
Super zaključak.
Bye-bye.
Bye.
Bye-bye, Shira. Bye-bye, Moitza. Bye-bye, everyone.
Bye-bye.
Thank you. Bye-bye.
Bye.
Bye. And of course, bye-bye, America.
Bye-bye, love. Bye-bye.
Da, imali smo homija, imali smo. Ja.